করবেন
No,
কি?
I told
উনি
sir to
জয়েন
join.
করছেন, আমি এইমাত্র ফোন করলাম, এখনই জয়েন করছেন।
ওকে।
Oh, আচ্ছা, আচ্ছা, just I think we can start. Let the Ashok Datta sir join, then sir will chip in. Okay. So very good evening to all. Again, from West Bengal Academy of Pediatrics, we have started the online symposium on very important topic that are required, or the topics that requires the day-to-day practice and very practically oriented topics. So this time it is the blood gas analysis, and the blood gas analysis, one of the topic that is taught in our medical schools from the day of the first year in the class of biochemistry. But still, this basic science has a lot of implication on our day-to-day clinical practice. We spend a lot of time during the rounds in ICU or in the emergency on analyzing the electrolytes and the blood gas of the patients, and its correlation to the clinics is very important. So for this, as we know, this is the important topic for the day-to-day practice. We are going to start this 2 days discussion on the symposium on blood gas analysis. So we are very happy that we have the guest faculties from JIPMAR Pondicherry, Professor Dr. Narayanan P. as the Professor of Pediatrics and also the in charge of the PICU, Head of PICU Unit, and running successfully the DM Pediatric Critical Care Program at JIPMAR Pondicherry. Also, we will have Dr. Suresh Kumar Onguran from the PGI Chandigarh tomorrow. And now today we have our Rohit Bhomik from AIIMS Kollani and Niladri Shekhar Bunian. They have worked very hard to formulate the program, and they will be the main coordinators of this 2 days program. So with this, I will hand over to our immediate past president of West Bengal IAP, Professor Kalpana Datta Madam, to say a few words.
Thank you, Mihir. Very good evening to everyone. I welcome all the faculties and the attendees. This is a very important discussion we have had in the last year also. This year we have again started. This is the first time we are having, because of some technical issues and all, it became 2 months time. So today's topic is blood gas analysis, learning in a different way. So as he has already explained what is the importance of blood gas analysis for the everyone. And if you understand the blood gas analysis, you can approach a diagnosis also. So if you misinterpret blood gas analysis, the diagnosis may be wrong also. It's very important for all the residents to go through the blood gas analysis very nicely and point to point. And I will also welcome our national faculty, Dr. Narayanan, and I think there is another national faculty, Dr. Guru Prasad, and of course Dr. Rohit and Nilanjan, who has worked hard, and I heard just now he has their all hard work. This is today we are seeing today, and without wasting much time, now the president of WAP has joined also. So my response is over. Thank you, Mir, for giving me the opportunity. Now I hand over the mic to you also. Thank you.
Yes, thank you, madam. So we have now Professor Ashok Datta, sir, President of West Bengal IIP, has joined. Also, we have the EB members, Dr. Nilanjan Ghosh, Dr. Shomir Ranjan Das here. So I will request Professor Ashok Datta, sir, to say few words. Sir, we have today's our national guest faculty, Dr. P. Narayanan P. has joined from JIPMAR Pondicherry. Dr. Narayanan is the professor of it and the Head of PIC Unit and running the DM Pediatric Critical Care program there in JIPMAR.
Thank you, Mayor. Thank you for this very important and very much beneficial discussion for the students, for the PG, and also for pediatricians who are working in the different places. I am thankful to those faculties who are giving time for this discussion. And I hope that this discussion will success and it will help, immense help to our students and faculties. Thank you.
Thank you, sir, for your encouraging words. Now, I will request Professor Dr. Narayanan to say a few words. Then after that, we'll go to the main program.
Yeah, can you hear me?
Yeah.
Yeah. First of all, thank the team at West Bengal Academy of Pediatrics for giving me this opportunity to interact with the students in West Bengal. As the previous speakers already mentioned, arterial blood gas is a very important investigation tool at the bedside for diagnosis as well as monitoring patients. And I'm sure that basics are all the basics will be covered in the next 2 days on this very important topic. I wish all the students a very enriching learning experience of 2 days. I hope you will enjoy the academic piece served over the next 2 days.
Thank you, Dr. Narayanan. So our other faculties, Dr. Ognishekar Saha has joined. Also, Dr. Sumanto Raut has joined. Now, Dr. Rohit and Dr. Niladri Shekhar Bunian are the two coordinators, and they have worked hard, and they will coordinate the whole 2 days program. And there will be last day, there will be exciting quiz. Last year also it was very successful, and all has enjoyed and we had also given the prizes for that. So over to you, Rohit and Niladri, for conducting the rest of the sessions.
Thank you, sir. Thank you, Mesa. Thank you, respected seniors and dear colleagues. So without wasting much time, I hand over the mic to Narayanan sir for starting the session, which is blood gas analysis is just not a number. It is an important tool. So, sir, the screen is yours. So, you are muted, sir. Sorry, muted, sir. Narayanan sir, you are muted, sir.
Yeah. Are you able to see the screen?
Yes.
Yes, sir. Perfect, sir.
Okay, good. Yeah, fine. Yeah. So, so good evening, everyone. So today's topic is given to me. The first lecture is blood gas analysis. Is it just numbers or an important tool? So in the next 25 minutes, it's not going to be a very long lecture. It's just an overview. So we're going to deal with what is the role of blood gas in a sick child and what exactly it measures, and with a few examples. But more importantly, what I like to stress, what we are not going to discuss in the next 20 minutes or so. We are not going to discuss acid-base physiology, interpretation of blood gas, or acid-base disorders, because these things will be covered by other lectures of the next 2 days. So you guys are going to listen to an ABG lecture without discussing acid-base physiology or interpretation or acid-base disorders. So sounds a bit vague. Even I was wondering what I should speak in this lecture without mentioning these things. So it's a challenge. So what I'm trying to deal with the overall concept and why it is such an important investigation, and what exactly exact information we get out of blood gas when we do it. I hope we'll do that. So let us start with 1 or 2 case scenarios just to set the stage. We will discuss this case at the end of the talk, so that there is more clarity. So the first case we have is a 1-year-old infant who complains of respiratory distress in his morning. The parents have brought him with that complaint. There was no history of fever, cough, anything suggestive of a respiratory infection. But when you examine the patient, we found that child is tachypneic and a doubtful dusky appearance, and we noticed that the saturation SpO2 was only 88 in room air. Even with oxygen, with a non-repeating mask, it was not improving beyond this. but the child had normal pulse volume, the blood pressure was normal, capillary refill also was normal. So hemodynamically stable child. And examination of the cardiovascular system and respiratory system did not yield anything. They were perfectly normal, appearing clinically. So the question we have is, do we need a blood gas in this patient? And if you need it, what is the reason and what are you looking for? Okay, so this is the first case. Now we'll go to the second case. These cases, the answers we will discuss at the end of the talk. So the case number 2 is an 8-year-old girl with the complaints of increased tiredness for the last 2 weeks. Parents have brought the child with this history. Mother feels the child has lost weight in spite of good oral intake. Over the last couple of weeks, there was no history of any fever or any contact with tuberculosis. On an examination, child appeared mildly dehydrated, mildly tachypneic, around 35 per minute respiratory rate, but saturation was normal in room air and hemodynamically stable. So do we need a blood gas in this child, and what are you looking for in this child? Then the third case is an 18-month-old brought with complaints of failure to thrive, weighing only 7 kilos at 1.5 years. The child's nutritional history seems adequate because he eats from a family pot. He eats a variety of family diet, what the parents eat, but he drinks a lot of water. That's what one of the history they're given. Clinical examination is unremarkable except for severe wasting. So in this child, do we need a blood gas, and what are we looking for? Okay, fine. So these 3 cases to set the stage of trying to see how blood gas can help us in some cases. Now let us first go to the answers we'll discuss at the end of this talk. So what does a blood gas tell us when we do a blood gas? So practically all machines, even the very basic machines of blood gas, will give you the measured parameters of pH, PA, partial pressure of oxygen, PO2, or partial pressure of carbon dioxide. This is given in all the machines, and most machines nowadays also give us the lactate and serum electrolytes, the basic electrolytes, sodium, potassium, some of the derived parameters like bicarb, base excess, the calculated saturation, and some machines with the co-oximetry can give us the actual measured saturation too. So this is what we get. These are the set of things we get, and we try to interpret them with the clinical context. So let us go into further details. So first of all, now why is it called a blood gas? Because we are testing a blood and we are saying blood gas, and we don't call it blood liquid or blood solid or some other test. So why blood gas? So the reason maybe is that it gives because it gives a lot of information about the partial pressure of respiratory gases in the blood. That is the reason we call it blood gas. So it gives partial pressure of oxygen and partial pressure of CO2. So before we go into the usefulness of this, let us understand what exactly you mean by partial pressure. Many of us have not fully thought about it, so I thought I'll discuss a little bit on what do you mean by partial pressure of a gas. So what do you mean by partial pressure? PO2 and PCO2, we commonly keep on referring almost every other day when you do a gas. So partial pressure, the best understanding is if you look at how it has been described in physics. So it is a pressure exerted by a gas of interest by itself in a mixture of gases. That's what is called partial pressure. For example, the room where we are sitting now, whether either in Pondicherry or in Calcutta, the room has a normal room air has the composition of basically nitrogen and oxygen, 80% nitrogen, 20% oxygen, more or less. The other gas are very less, and it exerts a pressure of around 760 millimeters of mercury. Okay, that is that is atmospheric pressure close to the sea level. Okay, so this is the pressure. So out of this pressure, 80% of the pressure is exerted by nitrogen and 20% of the pressure is exerted by oxygen, because they are more or less similar in their molecular weight. So the density is same. So the partial pressure of a gas, for example, partial pressure of oxygen will be 20% of the 760. 20% means approximately 1/5. That will be around 150. Okay. Similarly, partial pressure of nitrogen will be the rest of it, maybe around 600, because 80% of 760 will be around 600. That will be the partial pressure of nitrogen. This is easy for us to understand. And similarly, the partial pressure of oxygen in the alveoli, by the time we breathe in, we see, you might have read in books that it is around 80 to 100 millimeters of mercury. So I like to discuss this too, because the air we breathe in is 150 millimeters of mercury, the partial pressure of oxygen, the pressure exerted by oxygen. By the time it reaches the alveoli, we say it's only 80 to 100. So why that is? Because the air is the same and atmospheric pressure also is the same at the end of inspiration. The pressure in the alveoli is same as the atmospheric pressure. So why is it so? That is because the composition of air in the alveoli is different from what is there in the room. The alveoli, the air has a lot of, 100% saturated with the water vapor. Moreover, it also has a lot of carbon dioxide, which is continuously diffusing into the alveoli from the blood. So around 40 millimeters of mercury pressure is exerted by carbon dioxide, which is not there in this room. So when you minus that, it comes from 150, it comes to 80 to 100. So this is easy for us to understand up to this. Okay. Now the problem is, what is the partial pressure? But we do a blood gas, and we say the partial pressure of oxygen is the blood is this much. So how can you? What do you mean by partial pressure of a gas in a liquid? This is a difficult concept to understand. So okay. So now another important thing which I like to point out before this is, for example, suppose the partial pressure of oxygen I said in the room is 150 millimeters of mercury. Suppose I want to increase it. Say I want to make it say 300. Can I do it? What are the methods of getting the partial pressure high? I can get it by two mechanisms. One is I can increase the concentration of oxygen in the room from 20% to 40%, double it. So now there is more oxygen, so the oxygen exerts more pressure. So 40% of the composition of oxygen, 40% of the 760 will be around 300. I can do that. Another way of doing that, if I don't want to change the composition, is I can make this 760 millimeters of mercury, the pressure in the room, double. Okay, I can just double it, make it 1500. Then since the pressure in the room is double, 20% of that pressure, 1500, it will be around 300. So this is how a partial pressure of a gas, you can keep changing in the room, in the air mixture, by either by changing the composition or by changing the atmospheric pressure, in the room. Now, so what do you mean by partial pressure of oxygen in the blood? So here, partial pressure of oxygen in any solution, any water or blood or any liquid can be explained by this way. For example, suppose I take a glass of or a vessel of distilled water. Water distilled means it has nothing dissolved in it. It's pure water, and I keep it in this room open for some particular time, say 10 minutes or 15 minutes. Still, what will happen? On the surface of the water, the nitrogen and oxygen are applying some pressure. And as you know, every substance can dissolve. Water is a universal solvent. So this oxygen and some of the oxygen and some of the nitrogen will dissolve into the water after some time. The amount of oxygen and nitrogen which is dissolved will depend on, for the partial pressure of oxygen and get nitrogen above the water, and also the solubility of nitrogen and oxygen. So as I already mentioned, partial pressure can change with the composition and other things, but the solubility does not change. So it's constant for a gas. So suppose once the oxygen is fully dissolved, that equilibrium is reached, I measure the amount of oxygen dissolved in the water. I can guess what is the partial pressure of oxygen in the which the water is exposed to. For example, for ease of calculation, we can assume that the room we have 150 millimeters of in our room. I keep a water in it, and after some 10-15 minutes, I check how much oxygen is dissolved in the water, and I find that it's 15. I'm giving 15 number because it's easy for us to calculate. 150 here is so 15 milligram or picogram or nanogram or some unit, and it is constant. I mean, it's stabilized. So then I can guess that indirectly I can say that if I find 15 millimeters of 15 units of oxygen dissolved in any water, I can safely say that the water may be exposed to a partial pressure of oxygen of 150 because the solubility of oxygen remains constant. Okay, so now let us do one more thought experiment, so that we can understand this fully. For example, water in this room I said has 15 units of dissolved oxygen, and I said that that means that indirectly means that once the equilibrium is reached, it must have been exposed to a partial pressure of oxygen of 150. That is 15 is my own approximation. Okay, it is a random number. Now, how can we make it 60 units? Suppose we can make it 60 units. How can you make it? You have to make it 4 times. So either you can increase the partial pressure of oxygen. That means you have to increase the partial pressure of oxygen above the water 4 times. That you can do it either by increasing the atmospheric pressure in the room by 4 times, or increasing the composition of the FiO2 in the room from 20 to say 80%. Okay, now let us do a thought experiment where we take this distilled water from unknown planet. We take a distilled water in a sealed container and send it to some other planet through a rocket. Say Elon Musk is having the SpaceX. We send it. Then he keeps it there in some planet for half an hour and then seals it back and brings it back to Earth. I measure the amount of oxygen dissolved in the water. I find that it got 30 units of oxygen. Now, can you predict what is the partial pressure of oxygen in that planet? We can, because we know that water is by looking at dissolved fraction, we can predict. So since 15 units was dissolved when there was 150, so 30 units will be, so that the partial pressure of oxygen in that planet will be around 300, because that is the relationship which we established already. We know that. This is what we do when we do arterial blood gas. So when arterial blood gas says that the PO2 is 150 in the blood, that means looking at the amount of oxygen dissolved in the blood, in the plasma, blood means plasma, that is the liquid fraction, it appears that the blood was exposed to a a partial pressure of oxygen of 150 somewhere. Somewhere means it has to be only in the lungs. Okay, so indirectly can say that if you know that means if you know the PO2 in the lung, and if it is very close to the PO2 in the blood, that means the lung has efficiently transmitted all the oxygen into the lung. The lung oxygen delivery from the lung to the blood is very good in the lung. Okay, transport is very good. Okay, so PO2 and the alveolar PO2 we can easily guess because we are only giving the oxygen to a patient. We know what the patient is breathing, room air or whatever PO2 we're giving, and for a ventilator, what pressures we are using. So easily we can calculate the partial, we know the partial pressure of oxygen, what there in the alveoli. And if it is what we measure in the blood is almost very close to that, that means lung is functioning very well. And if it is very far away from that value, then means lung function is bad. So that is importance of doing a blood gas and looking at the partial pressure. So again, I'm just going to revise. So it gives a partial pressure of respiratory gases in the blood, the ABG. It gives a snapshot of the composition of gases the blood is exposed to in the lung. So what the ABG is saying is that looks like since the only place the blood can get exposed to air is the lung. So looking at the amount of oxygen dissolved in the blood, it looks like the blood has been exposed to this much partial pressure of oxygen in the lung. And the composition of air in the lung, alveoli, is known to us because we are only giving it to the patient. So if the values are very different blood gas, PO2 of what you measure in the blood is different from what you are calculating based on what the patient is getting, then we know that there is a problem. And so PO2 is hence PO2 is the arterial blood is a best indicator of lung function as an oxygenator. Okay, it is much better than even SPO2. SPO2 has got a narrow range. SPO2, the hemoglobin get rapidly saturated just with a very little oxygen, around 80 to 100 of PO2. After that, it cannot go high. So even if the PO2 is much higher, oxygen toxicity happens also, we cannot pick up SPO2. And SPO2 also less reliable when it falls less than 80. So SPO2 is not a good indicator of lung as an oxygenator. It's only it is better than nothing because it's non-invasive and so it is very easy to do. But the best indicator of lung as an oxygenator, any test is always partial pressure of oxygen in the arterial blood. Okay, we'll come to that again later in one of the cases. Now let us discuss what is homeostasis. This is very important when you discuss ABG. So what is homeostasis? This is one of the definitions which I found in one good, nice review article in Frontiers in Physiology recently in 2020. So it is a central unifying concept of physiology and defined as a self-regulating process by which organism can maintain internal stability while adjusting to changing external conditions. So homeostasis is a term which I'm sure all of us have learned in physiology and first BPS, physiology, biochemistry, everywhere. So homeostasis means our system is in a balance. The body, anything you take in the body is in balance and does a narrow range which we maintain. For example, our body temperature or our blood pressure, blood sugars, or our any composition if you take the pH of our blood, the osmolarity of blood, level of all the electrolytes, and everything is within narrow range, the biological range we keep. The body is maintaining that because of multiple mechanisms. It doesn't allow you to change much of protective mechanisms, maintaining all these things. So the maintaining everything within the normal range, physiological range is called homeostasis. So the homeostasis is essential for our survival. Homeostasis disturbed means we are sick and sometimes it's too much disturbed. We can actually even die. So blood gas is a good snapshot of our homeostasis. I'll tell you why. So it provides information. First of all, one of the most important functions is respiration for an organism. So it provides the information regarding respiration and gas exchange. We already discussed this. The partial pressures we measure in the blood is a very good reflection of lung as an oxygenator or lung as a carbon dioxide removal, both PO2 and PCO2. So it gives a very snapshot of how good is your lung functioning. Second thing is it also gives very good information about your cardiovascular status, or your oxygen delivery and how your cardiovascular system is functioning in an instant manner. Okay, it's in a real time data we'll get it based on pH and lactate. This we'll discuss subsequently in the next slide in more detail. And it also gives blood gas also gives information regarding the chemical composition of body fluids. The chemical composition of our extracellular fluid is essential for all functions of all the cells and all the organs, like pH and electrolytes. So that also it gives a snapshot of what's happening there. These two things we'll discuss in the subsequent slides. So cardiovascular status we'll discuss. Respiratory status we already discussed, PO2 and all that. So what is the function of cardiovascular system? To put it very simply, it is to match supply and demand with some amount of redundancies also is built in the system. That means what all the tissues and organs need, oxygen and other essential nutrients. What demand? It supplies all the demand with some amount of reserve. This is what the cardiovascular system keeps doing. It keeps on delivering oxygen to all the tissues and all the essential nutrients. And there is also a built-in some reserve. When the reserve is gone and the cardiovascular system is stressed, we go into a state of shock, but there is a supply-demand mismatch. Supply-demand mismatch means oxygen and other essential nutrients, what the tissues need, they don't get adequately. So there's a demand mismatch. This can lead to most important of those things is oxygen delivery. So if oxygen is not going to all the tissues and cells, they switch out to anaerobic metabolism and the lactate can increase. So when a lactate is a acid, lactic acid, when it accumulates, the pH can come down in the blood. So this is what we can easily pick it up on a blood gas. So a few lines on oxygen delivery for just for a recap on this. So all of us know that the amount of oxygen delivered to all our tissues is a product of these two parameters. Oxygen content means how much oxygen is there in each ml of our blood, how much oxygen is there in each of the blood multiplied by cardiac output. This is our oxygen delivery, which is constantly happening to all the tissues and cells. So the oxygen content can further be divided into two components. What is bound to the hemoglobin, which is hemoglobin into 1.36 into saturation, and what is dissolved in plasma, that is partial pressure of oxygen into the 0.03. So if a patient has say an elevated lactate or because lactic acid is accumulated and pH is less, it can also be due to lung problem or a heart problem. Gas, we can easily differentiate that because the blood gas, we can actually see the saturation and the PO2. That is normal. And especially the PO2 is normal. That means lung is working well, functioning well as an oxygenator. And in presence of that, PO2 is normal and if your lactate is high, you can always guess that there is a problem with the cardiac output. Either, provided of course the hemoglobin is normal. That is easy, we can find out. HB is very easy found out. Clinical examination, the hemoglobin is normal. So hemoglobin is normal and PO2 from the blood gas is normal. We know that if lactate is high, the first possibility is a cardiac output. That means blood gas also can give you a snapshot of your cardiac output in addition to your respiratory system. Now, what about chemical composition of body fluids? So we know that our extracellular fluid should maintain its pH, solute composition, both osmolarity and it contains lots of electrolytes, chemicals, organic acids, inorganic substances, for example, sodium, potassium, calcium, all those things. And as part of the homeostasis, very important. The composition is very important because all our cells are bathed in the ECF and the blood, and so the cellular functions, their cell membrane potential, everything depends on the ECF maintaining this composition perfectly. So if that is not maintained, cells can malfunction, and there are multiple processes. You learn in this subsequent lectures about buffers and all. So the buffering system. There are multiple defense mechanisms against changes in any of these things, pH or even osmolarity, composition of any of the electrolytes. There are multiple processes in the body which acts as checks and balances for all these things to maintain this under narrow limits or maintain the homeostasis. And blood gas, when you do the blood gas, we get an idea of these things, how these checks and balance are working, and changes in these parameters reflects the pathological process and provides us clues to the diagnosis. For example, acid-base status. So what is actually pH? pH is the all the negative logarithm to the hydrogen ion concentration, all that. So hydrogen ion concentration of the blood, that is actually as a balance of all the acids. So in our body, the constantly producing organic acids, there are bases, there are inorganic substances. So all of them, what is the net balance of all the acids and bases in your body? And that is the pH. And pH, we have a narrow range, around 7.35 to 4.5. If there is change in pH, means there is an imbalance of some of this acids and alkalis. We immediately get to know, and then depending on the clinical status, we can actually guess what is going on in the patient. And blood gas also gives most patients will give an electrolytes, not only the composite look of the pH, it also gives the individual electrolytes, sodium chloride, calcium, potassium bicarbonate, all that, so that we'll know which of these things are deviations in one of these things can give us clues of what is the chemical disturbance which is going on in the body. So to again summarize, blood gas is a snapshot of our entire body's homeostasis. It gives information about respiration, that is gas exchange, how effectively lung is oxygenated by PO2 and PCO2 and removing carbon dioxide, and provides information regarding the cardiovascular system, oxygen delivery, and other things by pH and lactate. It also gives the information regarding the chemical composition of our body fluid. It's essential for cell function, which is pH and electrolytes. So overall, we get a snapshot of the entire homeostasis of our body, the vital functions, all the vital functions in one investigation. So that is the advantage of blood gas. Now, with this information, let us get back to the cases which we discussed. Okay, so case one, we had a child who is actually sounds hypoxic to us because child is having tachypnea and child is also having respiratory distress and saturation is also low and it's not improving with the oxygen. So in this situation, since clinical examination of the cardiovascular system and respiratory system are normal, we're confused. And the patient looks hypoxic, but we don't have a cause. So the next best important investigation I told you is the blood gas here in this patient. Why? Because it is if we know the PO2, we know whether we want to know whether the lung is functioning normally or not. There's nothing to suspect a heart disease in this patient. So the lung is functioning normally or not, a patient was low saturation. So we did a gas on this patient and we found that, of course, it has to be arterial blood gas, not a venous. We found that PO2 is 300. That is because the child is on a non-rebreathing mask. So when you give an NRM oxygen, the amount of FiO2 the patient is breathing will be close to 100% theoretically, but practically it will be around 85% according for some leak. And usually, if you're breathing FiO2 of 80%, that means your PO2 in the lung will be almost 4 times your FiO2, 4 to 5 times. So it will be around 300 to 350 is the PO2 in the alveoli. So that is reflected in the blood. PO2 is 300. That means it is very close to the what the patient's partial pressure of oxygen in the alveoli. That means lung is functioning effectively. Lung is transferring the oxygen effectively to the blood. So lung is not the issue. Then why this patient has low saturation? Of course, whenever PO2 is normal, we should not blame the lung for any cyanosis or low saturation. That means something else is wrong. So next we have to think at the heart. Any shunt happening in the heart, but this child is a previously normal child. No past history of cyanosis. The CVS examination is normal. So unlikely he has a complex cyanotic heart disease. When that is ruled out, the next possibility is this patient is there is something wrong with the hemoglobin. The hemoglobin is not normal. That's why the patient is looking not responding to oxygen. So this child actually had a methemoglobinemia. Okay, that was the problem. So some it was exposed to some oxidizing agent and it was a methemoglobinemia in this child. So here the blood gas is a clue to give the diagnosis, and finally it can be prone. I mean, we can look at the methemoglobin level. Some of the blood gas machines even give it directly. Okay, so you see here the clinically it is impossible to rule out sometimes a pulmonary disease or a pulmonary gas exchange issue. But PO2 if is normal, you can be reassured that the lung is not the culprit. Okay. Now coming to case 2, here we have this child who came with some tiredness and all that, and child was complaining of loss of weight and this thing. So what we notice is that child has mild dehydration and some tachypnea. But the tachypnea is not producing any hypoxia, and the child is hemodynamically stable. So a child who is breathing fast without no cardiovascular or respiratory involvement, you should suspect some metabolic problems usually. They may be trying to compensate for something. So this patient definitely needs a blood gas. So this patient, we are not bothered about the lung function here because saturation is normal. So we did a VBG in this patient and found that pH is low. Patient is actually acidotic. So patient is compensating for the acidosis, metabolic acidosis by trying to trying to wash out CO2. That tachypnea is because of that. So bicarb is also low. So immediately we got a clue for the diagnosis. Patient having unexplained acidosis. We checked the blood sugar. Of course, it was 500. So this child is a case of diabetic ketoacidosis. So this blood gas gives a snapshot of the chemical composition of this patient, the pH and other things. Because since patient's clinical status made us suspect that some patient is compensating for some metabolic problem, the investigation of the bedside will be most useful will be a blood gas. Now the case 3, we have a 18-month-old child who brought with failure to thrive, weighing only 7 kilos, and of course any child with failure to thrive, nutritional problem only we think first, but here the nutritional history was more or less unremarkable. Child seems to be eating properly. The diet seems appropriate for the child, but there's a history that child drinks a lot of water. And the most important thing is, of course, in a failure to thrive child, once you know that it's not nutritional, we look at all the organ systems one by one, starting from each of the organ system, cardiovascular, respiratory, any chronic illness. We cannot find any evidence in this child with the initial evaluation. So now do we need a blood gas? Yes, because once we don't have an obvious cause for, after ruling out nutritional problems and an obvious organic cause in the initial screening, always suspect that there could be something in the homeostatic milieu, in the chemical milieu. So in this child, we took a gas again, venous blood gas. We found again child had acidosis with the bicarb of only 14, and subsequently when he walked up, the acidosis was not, because the previous child, with the diabetic ketoacidosis, the acidosis was an increased anion gap acidosis. I'm sure they'll be discussing further. So that there the acidosis is because of accumulation of keto acid. In this child, we found that the acidosis was not because of accumulation of any external acid, because of loss of bicarb from the body. So there we say it is a normal anion gap or normal anion gap metabolic acidosis. Acidosis is without any anion gap. Okay, this will be discussed in subsequent lectures by others. So this child had a non-anion gap metabolic acidosis. Bicarb was getting lost from the body through the kidney. So this child turned out to be a case of renal tubular acidosis. Okay, so now I think that's it. I think coming to the end of my lecture here. So what are take-home points from this lecture? Blood gas is a snapshot of our homeostasis, starting from respiratory, cardiovascular, as well as the chemical composition of our body fluids. Single snapshot, you get a lot of information, a real-time information. Okay, and so it gives in any sick child, it gives the snapshot of the degree of sickness of the child, and of course, and another most important thing is clues to the mechanism, so that the diagnostic clues we can get from gas, and repeated values also help us in monitoring. Once see an abnormality, we can actually correct that and see how the patient is responding to your treatment. So repeated blood gases at predetermined intervals can tell you about the patient's progress, and is arguably the most valuable point of care test in a sick child. So that's why we should be very well versed in interpreting this test. It's a very useful test, one of the most valuable point of care tests in a sick child. And I'll stop with a caveat that any other investigation, clinical context is everything. Please don't interpret ABG alone. Most of us are like just showing an ABG sitting in an AC room, the computer screen. What is ABG and diagnosing the patient? Please don't. When you actually treat a patient, make sure that you always know the clinical history. We know the clinical the examination findings and other investigation, and ABG should be interpreted in the clinical context. Otherwise, you can make mistakes. Even the best ABG interpreter among all of us, most experienced person also can can make a wrong diagnosis if you're given only the ABG without the clinical context. So that's everything, like any other investigation. Thank you.
Thank you, sir, for a very nice and lucid explanation of why we need ABG. So a few questions came that we answered in the chat box only.
Okay.
You can ask again, Rohit, you can just put the question again.
Yes, Niladri, can you just take the question and answers? So Niladri is also joined. Niladri is our assistant professor in AIIMS Kalyan.
Yeah.
So, sir, there was one question where you have already explained it, sir. So they have asked why the PO2 in alveoli was less than the PO2 in the air.
Yeah, that I already mentioned. The composition is important. PO depends on the composition. So alveoli, composition of air in the alveoli is different from what is there in your room air, because they have more of carbon dioxide and 40 millimeters by carbon dioxide, and of course saturated by water vapor. Yeah.
Yes, sir. That's all.
Any other questions?
Did I exceed the time? I thought I could.
No, sir. No, sir. No, sir.
No, it's okay. So well within time. So any panelist have any questions? So one question is ABG versus VBG. I think what is the difference? I think he's asking. I think that will be taken care of. No, the topic is there.
Yeah. We have a troubleshooting.
Yeah. I think there'll be. Obviously, and arterial blood gas shows the arterial values, and the venous blood gas shows the venous values, depending on the context. So when you want to assess the function of the lung as an oxygenator, always take an arterial blood gas. If that is not the aim, you are not bothered about finding out the aim of doing an ABG is not to find out the lung function as an oxygenator. Then all other practical purposes, a VBG will do. Mostly VBG will do for most practical purposes, unless you want to know the lung function. That is the answer, I think. A short answer. The long answers others will give in the subsequent lectures, I hope.
Yes.
Thank you, Dr. Narayanan, for your valuable time and very lucid and very highlighting very important aspect of the role of ABG to determine the body hemostatic status at the moment of a sick child. Thank you again. And I think we can just move forward.
Sure.
Thank you.
Okay, sir. Thank you, sir. Bye-bye.
Bye-bye, sir. Thank you. Bye-bye. Thank you.
So after very interesting first talk, we will have our next session. It is on basic physiology of acid-base balance with compensation, understanding of compensation, and the Henderson-Hasselbalch equation. So we have none other than Dr. Agnishekar Saha, which all of you is knowing is the expert in this topic and is a very senior intensivist in Bengal and Kolkata. So, sir, the stage is yours, sir.
Sure. Thank you, Rohit. Can I share my screen?
Yes,
Yes,
sir.
yes.
Yes, sir.
Yeah. Let me check. How can I go to full screen from here? Oh dear. Oh, this is. Let me just minimize that. Yeah. So, and then. Yeah. And I'm audible, yeah? I'm audible?
Yes, sir. Yes,
Yes,
sir.
yes, perfect.
Perfect, sir.
Fine. Thank you for having me. So for the next about 25 minutes, I have not timed my lecture. This is the only problem. We'll talk about Henderson-Hasselbalch equation and how is it related to ABG. So what we'll talk about, we'll start with law of mass action, and then we'll talk about the Henderson-Hasselbalch equation in general, and then how it is applied in biology. Then what this has to do with ABG, what is compensation, and then we'll also talk a little bit about Davenport. The Davenport diagram, which is a useful tool. I hope you'll find it. The thing is, for the first 3 or 4 slides have quite a bit of some bit of maths in it. So if you are somebody who gets really switched off, if you see anything more than one equation, then don't bother. I mean, for the first 3 or 4 slides, you may find it difficult to follow. If that is the case, let it be. Then at one point, we'll come back. That will be just about first 2 to 3 slides. And then after some time, we'll come back to the crux of the matter. And from there on, I'm sure you'll be able to follow it. So if you can't follow the initial 2 or 3 slides where we have got a bit of maths, don't worry. But we have to do that to sort of, build how it all started. So it all started with the law of mass action. What is it? In its generalized form, it says for a chemical reaction, generalized form, the rate of the reaction is proportional to the product of the reactants raised to the power of their stoichiometric coefficients. So what does that mean? So if, say, A molecules of A adds with B molecules of B to give C molecules of C and D molecules of D, then the rate of the equation will be A to the power A into B to the power B. Why? Because A or B are the reactants, they are on the left-hand side of the equation, and small a and small b are their stoichiometric coefficients. So, and we know if anything is proportional, the proportion sign can be replaced with a constant, which is called the proportionality constant. So we can also say that the rate is equal to K into A to the power A into B to the power B, where K is my proportionality constant, which is a constant, right? So for example, if 2 sodium plus 2 water gives 2 molecule of NaOH plus H2, then the rate will be equal to K, which is a proportionality constant, into Na to the power 2, because 2 molecules of sodium are there, into concentration of H2. These are all molar concentrations, remember. These are all molar concentrations. So concentration of H2 time again squared, because there are 2 molecules of H2. Now, for a reversible reaction where A molecules of A plus B molecules of B interchanges with C molecules of C and D molecules of D, then you have got 2 reactions. One is the forward reaction where A plus B, A and B is giving rise to C and D. For the forward reaction, we can say from the previous reaction, so rate for the forward reaction is equal to constant for the forward reaction into A to the power A into B to the power B, just like the previous one. Now for the back reaction where C and D are combining to form A and B, C and D becomes the reactant. So now rate for the backward reaction will be proportionality constant for the backward reaction into C to the power C into D to the power D, because C and D are the reactants now. And at equilibrium where A, B, C and D's concentrations are equal at equilibrium, we can say that the rate for forward reaction is equal to the rate for the backward reaction. So R for is equal to R back. And then if we just replace that, then it becomes K for forward into A to the power A into B to the power B is equal to K backward into C to the power C by C D to the power D. And if we rearrange that, then we become K forward by K backward is equal to C to the power C to the power D by A to the power A, B to the power B. Now K forward is a constant, K backward is a constant. So their division will also give rise to another constant. And we call this Ka, which is again a constant. That is CD by AB. Now, if we just take the stoichiometric equations away, so we say one molecule of A plus one molecule of B gives rise to C and D, then this same equation takes the form of Ka is equal to C into D by A by B. Or in other words, for a reversible reaction, the molar concentration of the products and the molar concentration of the reactants, their ratio is constant. How does it apply to a weak acid? So for a weak acid, you have got HA is a weak acid. So if we add water to it, it will partially dissociate into A minus and H plus. That's the nature of a weak acid. It partially. So it is a reversible reaction. So from the law of mass action, again, what we find, what we have just done previously, so we can say Ka, which is a constant, is equal to product of A into H, their molar concentration divided by molar concentration of H, which is the concentration of the acid. Remember, the H2O is not taken care of because it is not really taking part in the reaction. Now we take logarithm of it, of both sides. So we get log of Ka. Remember, Ka is a constant, right? Is equal to logarithm of A into H by HA, their molar concentration. We just rearrange it so that we said A into H, we say H into A. Now, how log works, we have forgotten a lot of it, but you remember log A into B is equal to log A plus log B. Okay, log A into B is equal to log A plus log B. Now we can say H into A by HA, we can say that like H into A by HA. So then we can rewrite log of K is equal to log of H plus log of A by HA. And then if we just rearrange it, what we get, minus log of H is equal to minus log of K plus log of A by HA. Now, my negative logarithm can be expressed as small p. So remember, so we can say negative log of H plus, we can say that as pH is equal to negative log of K. So we can say that pKa plus log of A by HA. Now, so this P is not partial pressure. It's important to understand that this P stands for negative logarithm. And there we get the famous HH equation. So pH is equal to pKa plus log A by HA for a weak acid. So P means negative logarithm. Now, what does that mean? Two things you need to remember. One is logarithm is a scale where if log A is equal to X, then log 10A is equal to X plus 1, log 100A is equal to X plus 2. So that is how the scale works. And because it is negative logarithm, so if the actual product increases, then its pH, the concentration of the product increases, its pH decreases. Whereas if the concentration decreases, the pH will increase because it is negative logarithm. Right. So how does it apply to biology then? If we just use the HH equation for CO2 plus H2 is equal to H2CO3, this is the most important application of HH in biology. Carbon dioxide plus water making carbonic acid, which dissociates into H plus and bicarb, right? And if we just apply the HH equation, the Henderson-Hasselbalch equation, then which we have just done previously, so we can say pH is equal to pKa, which is the dissociation constant for carbonic acid, plus log of bicarb by H2CO3, carbonic acid, right? And so we can rearrange that. So we can say pH is equal to 6.1. Why 6.1? Because 6.1 is the dissociation constant for carbonic acid. So 6.1 plus log of bicarb by, now carbonic acid is a very unstable product. It's very difficult to measure it. But we know the amount of CO2 actually gives rise to the carbonic acid. So we can replace the molar concentration of carbonic acid to molar concentration of dissolved carbon dioxide. So that's what we have done. pH is equal to 6.1 plus log bicarb by molar concentration of dissolved CO2. Now, we do not really measure the dissolved CO2's molar concentration. But what we measure partial pressure of CO2. But we know they are also related by the 0.03, because 0.03 is the solubility constant. So we can replace the molar concentration of CO2 by 0.03 into PCO2, because that is the molar concentration, and we measure PCO2. So this ends the maths bit. So people who are worried about the maths bit, please come back to the lecture. So now what I've got is pH is equal to 6.1, which is a constant, plus log of 0.03. 0.03 is a constant. The only variables we have is bicarb, molar concentration of bicarb by PCO2. So that ratio. So it is very, very important to understand that pH is essentially a function of bicarb by PCO2. That is the crux of the matter. Now, from there on, we can follow everything. So what does that mean? So pH is essentially expression of bicarb by PCO2, right? Now, the PCO2 is controlled by whom? The lungs, right? And we can get rid of PCO2 very fast by just panting, by just breathing fast. So anything related to PCO2 for acid-base terminology, we call it respiratory. If it is primarily related to PCO2, and it is primarily controlled by our lungs. Whereas bicarb is primarily controlled by the kidney, and this control happens slowly over a period of time. And anything that is related to bicarb is called metabolic, right? And now human body, being an inactive system, we try to maintain our pH within a very narrow range of 7.35 to 7.45, because if our pH goes beyond this, then a lot of our body function starts getting disturbed. So what happens? The body tries to maintain the pH within a narrow range. And we know our pH depends basically on the ratio of bicarb by PCO2. So body basically essentially tries to maintain this ratio constant. So if suppose HCO3 bicarb goes up, if the bicarb goes up, then the ratio goes up. Body wants to bring back the ratio back to normal. So how can it do it? Only by increasing the PCO2. Or suppose the bicarb has gone down for some reason, then the value of the ratio goes down. The body would like to bring it back to normal. How can it do it? There is only one way, by reducing the PCO2 so that the ratio becomes normal. Okay, so that is the basic structure. And this, the initial change is the primary change, and then the subsequent change which the body does to maintain the ratio is called the compensation. For example, so my pH is proportional to bicarb by PCO2. It is actually a wrong statement. It is not proportional. But what you can understand, just for the understanding check, if the ratio increase, sorry, if the ratio increase, the pH will increase. If the ratio decrease, the pH will decrease.
Me, sir.
Please mute this.
Me, sir. Please mute, sir.
Right.
Sir, please, could you mute?
Okay. So if the ratio increase, the pH increase.
HPV টা এখানে নেই, pneumococcal এটা cervical cancer.
And if the ratio decrease, the pH decrease. It is Can you hear me?
সার্ভাইকাল ক্যান্সারের 3টে ডোজ পরে
Oh. Hello.
Sir, you are fine, sir. I'm just calling, sir, for mute.
Right. So if the bicarb rise, as you can see, that the ratio will increase. As the ratio increase, the pH will also increase. As pH increases, we call it alkalosis, right? And as the pH increase, my actual sodium hydrogen concentration decrease, and we call it alkalosis. So this is alkalosis, and why it has increased? Because my bicarb has changed. So anything related to bicarb is metabolic. So we'll call it a metabolic alkalosis. And what the body will do to maintain the ratio, it will increase the PCO2, right? So that is the respiratory compensation. Whereas if the bicarb falls, then the ratio falls. If the ratio falls, then my pH also falls. And if my pH falls, we call it acidosis. So this is the acidosis. It has happened primarily because my bicarb has fallen. So we call it a metabolic acidosis. And what will be the body's response? Body will also try to bring the PCO2 down. So that is my respiratory compensation. On the other hand, if PCO2 rise, what will happen to the ratio? The ratio will fall. So if the PCO2 rise, my ratio falls, so my pH falls. When my pH falls, we call that acidosis. So this is an acidosis, which is primarily because of PCO2 change. So we call it respiratory acidosis. How will the body react? The body will also try to bring the bicarb, sorry, what did I say? If the PCO2 rise, if the PCO2 rise, then the ratio will reduce. So we will get acidosis. So it is called respiratory acidosis. So as the PCO2 has risen, so how will the body react? Body will also increase the bicarb to maintain the pH similar. So that is my metabolic compensation. Whereas if the PCO2 falls, what will happen to the ratio? The ratio will rise. If the ratio rises, we call it alkalosis. So this is the primary respiratory alkalosis. And how will the body react? The bicarbonate will also fall because the PCO2 has fallen. So now the metabolic compensation will be by reducing the bicarb. Remember, where the change is related to bicarb, it will happen gradually. So we'll have an acute compensation, and subsequently we'll have a chronic compensation. So that is it. So if you have a metabolic acidosis, your pH drops, your H+ concentration goes up, your primary disturbance is bicarb gone down, and your compensation is PCO2 will go down. Remember, the compensation, the primary disturbance and the secondary response will always go in the same direction. Whereas if it is metabolic alkalosis, because it is alkalosis, my pH will go up, my hydrogen concentration go down, my bicarb will go up. That is my primary change because it is metabolic. And my secondary response will PCO2 will go up. If it is respiratory acidosis, it is acidosis, so pH will go down, H+ will go up. My primary disturbance is PCO2, which has gone up. My secondary response will be bicarb going up. If it is respiratory alkalosis, then my pH will go up because it is alkalosis, H+ go down. My primary disturbance, my PCO2 has gone down. That is why I'm respiratory alkalosic. And my secondary response will be bicarb will fall down. Now, this is called the Davenport diagram, and I hope you will find it useful to understand this a bit more. Looks a bit busy initially, looks a bit complicated, but it is not actually. On the x-axis, we have got the pH, which is increasing 7.0 to 7.1, 2, 3, 4 like that. So this is the pH. On the other hand, we also have got this is the H+ concentration. As you can see, as the pH goes up, the H+ concentration goes down. But we don't usually look into H+ concentration. So on the y-axis, we have got concentration of bicarb, which is sort of, going up from 4, 8, 12. And 24 is the standard bicarb, normal bicarb. 7.4 is the standard pH. And these carved lines, these are for PCO2. And as you can see, as we go from right to left, so left to right, the PCO2 goes up. So this is PCO2 10, 15, 20, 25, like that, 80, 90, 100. Now, where is my normal? My normal bicarb is 24. My normal pH is 7.4. Where do they intersect? They intersect here. And if we just follow this line, look, this is the PCO2 of 40. So that is my normal PCO2. So this point is the normal point where my bicarb is 24, my pH is 7.4, and my PCO2 is 40. Now, what happens in respiratory acidosis? So we are starting with a normal bicarb, a normal PCO2, and a normal pH. Now, this is respiratory acidosis. So what will happen? My PCO2 will go up. Let's see. This is what has happened. So see, my PCO2 has gone up from 40 to 80. But my bicarb, let's say, remained the same. So I will just follow this line because now my PCO2 is 80. So I am following this until I reach the bicarb of 24. So we reach this point. And what is my pH now? We just go down to the x-axis, it is 7.1. So my pH has dropped from 7.4 to 7.1. So that is my respiratory acidosis which has happened. Now, how will the body react? Body will do a metabolic compensation. So what has happened? My bicarb has gone up from 24 to 28. So as a result, my PCO2 is still 80. So I will follow this line, but go up to this level because my bicarb has gone up to 28. So my pH, as you can see, which was 7.1, has come down, has gone up to 7.15. This is the acute compensation. If we stay there for a bit longer, this compensation goes further. So now what happened? My bicarb has gone up from 28 to something like 38. So my so I just go further up along this line because my PCO2 is still 80. So I reach there. So I just come down. And what is my pH now? My pH has gone even further up to 7.3. So this is what has happened as a chronic compensation. Let us see what happens for something like metabolic alkalosis. Again, we are starting with 24, normal bicarb, normal pH, normal PCO2. Now this is metabolic acidosis. So my bicarb will fall down, right? So what has happened? My bicarb has fallen down from 24 to 12. My PCO2 remains same. So I am following this number, this line, PCO2 of 40, and I am reaching this point. So my pH has fallen from 7.4 to 7.1 without any compensation. So for no compensation. So what will happen? Body will compensate by what? By doing by reducing the PCO2, right? So this is what has happened. So my PCO2 was 40. Now my PCO2 has fallen down to 25, right? And what has happened? So what will happen? My bicarb remain 12, but I will come down to this point. Why? Because this is the line for PCO2 of 25. My PCO2 of 25 coming down to a bicarb of 12. And what is my pH now? Look, my pH has from 7.1, it has increased to 7.3. So that is what happens for metabolic acidosis. Now let us say what happens for something like respiratory alkalosis. I hope it is respiratory alkalosis. We are again starting from the same point, 24, pH of 7.4, PCO2 of 40. Okay. So primary respiratory alkalosis. So my PCO2 has fallen down from 40 to 25, but my bicarb remained same, 24. So I have reached from this point to this point because this is the point for, this is the line for PCO2 of 25. And you see your pH has gone up from 7.4 to 7.6 because I am here. So what will body do? Body will try to compensate by reducing the bicarb. So what happens? So my bicarb has fallen from 24 to 20. So my PCO2 remained 25, but my bicarb has fallen to 20. So I am there. So my pH, which was around 7.6, now has gone down to just over something like 7.5. This is acute compensation. If we continue doing that, then my bicarb falls further down, something like 18, so that I come from this point to even this point. This is the point for PCO2 25. We are assuming that our PCO2 remains 25. So I'm reaching this point. So my pH is now 7.45 rather than 7.5 something. Okay. And the last example, metabolic alkalosis. Again, we are starting with pH bicarb of 24, PCO2 24, PCO2 40, pH of 7.4. Now it is metabolic alkalosis. So my bicarb will go up. So what happened? My bicarb has gone up from 24 to 40, but my PCO2 remained 40. So what has happened? I will just follow this line of PCO2 40 up to this level where my bicarb is 40. And so what has happened to my pH? From 7.4 to some just above 7.6. That's quite alkalotic, right? So that is without compensation. Now the body will try to compensate by how? By increasing the, but will try to become acidotic by increasing the PCO2, right? So my PCO2 now increases to 50. So my PCO2 has gone up from 40 to 50, so that by this point, I am going to this point because this is the point line for pH of PCO2 of 750. So I am this point. So my pH has gone down a little bit from something more than 7.6 to something more than 7.5. So this is my compensation. That ends it. So take home message, pH basically is a function of the ratio between bicarb and PCO2. Bicarb driving the pH up, which is alkalosis. PCO2 driving the pH down, which is acidosis. Any change in bicarb is termed metabolic, while any change in PCO2 is termed respiratory. Any rise or fall in either bicarb or PCO2 will cause the same change in the other. Okay. Large change in pH is very harmful for the system, and the body basically tries to restore the pH by causing similar change in the other parameter so that the bicarb is to PCO2 ratio, which is what it is all about, remains same. Thank you.
Thank you very much, sir, for very nicely elaborating the concept of compensation. So, Dr. Niladri, any question answers are there? The questions are there?
Yeah. Sir, they have, I think, two of the participants, they want to once again know about the compensation, I think. They have written.
Shall I stop sharing?
Sir.
Yes, sir. Yes, sir.
How do I do that?
Sir.
Share option, sir.
I've got new share.
Rohit, sir.
I've got new. Oh,
yes.
Yeah.
Two of the participants, I think they want to once again want to just tell sir to go through about the compensation part once more.
Right. Look, what the body tries to do is body tries to maintain the ratio of bicarb by PCO2, not the exact value, but the ratio. It's important to understand that the ratio matters, not the absolute value of either bicarb or PCO2. The ratio has to be constant. Now, suppose for some reason, okay, whatever is the primary change, for some reason, one of the thing has changed. Say bicarb has gone up, right? If the bicarb has gone up, but I still want to maintain the ratios same, how can I do it? Suppose your bicarb has doubled. If your PCO2 also doubles, then the ratio remains the same. And that is what the body essentially tries to do. So if your bicarb goes up, that is your primary change. So we call it a metabolic change because it is bicarb. And then what will the body do? Body will try to restore the ratio. So what if the bicarb has gone up? To maintain the ratio, the PCO2 has to go up. Otherwise, the ratio will not. So what will happen now? My PCO2 will also go up. So that is the respiratory compensation. So if you are become metabolic alkalosis, you will breathe less so that your PCO2 goes up. Whereas if your bicarb has gone down, then the ratio has gone down. Okay. But the body does not like it. Body wants to go back, bring back the ratio back to what it was. My bicarb has gone down. So my PCO2 also needs to go down. Then only the ratio can be okay. So the body tries to bring the PCO2 down. How we do that? By panting. So that is why when you become metabolically acidotic, then your respiratory rate goes up so that your PCO2 goes down.
Sir, another two questions are there, sir.
Sorry.
Yeah. Ogni sir, another question is how to differentiate mixed disorders from partial compensation?
How to differentiate mixed disorders from partial compensation? Right. I mean, this needs a lecture, and I'm sure we'll cover it, isn't it?
Yes, sir. Yes, sir. We will go ahead one by one. Like we have sessions on metabolic acidosis as well as respiratory component. So probably at the end of the sessions tomorrow, we will put it.
Yeah, I mean, this is a very good question, but
Yeah.
I'm sure, whoever is interested, please, it needs a talk. It needs a talk, and that talk will be delivered. So stay tuned.
Another question is, sir, when the PCO2 value is in between two adjacent lines, which line should we consider?
Dr. Momita has asked, yes, sir, this question.
Mm-hmm. In the Davenport diagram, you mean?
Yeah. They want to see the diagram.
Right. Number one, look, I mean, what is the role of Davenport diagram? Davenport diagram is basically a tool to make you understand what actually happens. We don't really use it in our clinical practice. Number one, I think it is a tool to really understand what happens when, because every point in that graph gives you an acid-base status. So that is primarily its use. And if you are talking about somewhere in Beethoven, you just have to approximate. You can use it to actually, if you have an ABG value and you can plot it in a Davenport diagram to see exactly what is happening, you can do that. But I think it is more of a tool for understanding rather than clinical use.
Yes. So another question by Dr. Anand, if there is overcompensation when we are dealing with mixed ABG. So if there is overcompensation, then we are dealing with mixed ABG disorder. Somebody is saying if something is showing like overcompensation.
I think that is more of an answer, possibly. Someone is like, you are absolutely right. You are absolutely right. That, the compensation can never go over. Okay. Suppose I've got a primary acidosis, right? So if I've got a primary metabolic acidosis, then my PCO2 will go down, thereby causing a respiratory alkalosis. But that alkalosis can never make me overall alkalotic, or in other words, my pH can never go more than 7.45. If that happens, then we need to understand that something else is happening. It cannot be just compensation. Absolutely right.
So, do we have to talk where we are plan changes in ventilatory parameters based on ABG value? Ventilatory parameters change based on ABG value. Yeah, we will discuss some component in the respiratory.
Another last one is there. They want to ask, how does kidney compensate to maintain the pH? That is also, I think, sir, a big topic itself.
Well, for this, at least for this moment, let us remember this, that kidney primarily secretes H+, but it also conserves bicarb, right? It also conserves bicarb. But how much does it conserve? How much will it conserve? It can also control that, right? So if you are conserving less, that actually means you are losing it. Or if you are conserving more, then that means you are adding it, right? So let's think of it that way. The bicarb is actually reabsorbed by the kidney, essentially, and H+ is secreted. Now, if the body wants to get rid of some bicarb, what will the kidney do? Kidney will reabsorb less bicarb. That means body is losing more bicarb. Whereas if the body wants to retain bicarb, then that because we have got some respiratory acidosis, we want to compensate it. So we need some extra bicarb. Then what will do? The kidney do? The kidney will retain more bicarb than usual. But it takes time.
Thank you, sir. Thank you very much for nice explanations for the questions.
Thank you.
And as we understood that the compensation is very much important, and here sir has explained CO2 and bicarb. So since our student life, we understood that acid base is all about CO2 or bicarb. Then in the latter part, we understood something else is also there. It's not all CO2 and bicarb. So for that discussion, we have Dr. Guru Prasad with us, who will tell that it is not about CO2 and bicarb. There is something else is also there, and that is called Stewart approach. So Dr. Guru Prasad is right now PICU consultant at Ramakrishna Mission Seva Pratishthan, Kolkata, and he has his training in pediatric critical care from Manipal, Bangalore. So Dr. Guru Prasad, please go ahead. Your screen is.
Am I audible?
Yeah, you are audible. Just full screen, please.
Right. So completely, yeah, right. So I'm first of all thankful for this opportunity to be a part of this online teaching program, and it's also fun to be covering a topic which is not generally used by us as well. So it is a little difficult to give a complete view of those two, an entirely new approach within 25 minutes. So what I will be trying to do is that I will try to give an overview of the type of principles and the type of concepts which are used to develop this particular approach, with some little examples of its application. Right. So we all know that the standard basics model of acid base is what we are all using. This model, of course, has enjoyed much success. That is why it is used very widely. It is relatively easy to understand. And the plus point is that it is relatively simple mathematically, and it relies on easy to measure variables. So, but however, some people are not happy with this. So they are saying that this model focuses a lot on what is happening, trying to tell us what is going on, rather than giving a natural and an explanation based on why this is happening. So what some people would like to do is that they want to apply the laws of physical chemistry to the human plasma, then develop a model of the human plasma, a mathematical model of the human plasma, and sorry, there is something wrong with this. 1 minute. All right. So a mathematical model of the human plasma, and then apply it to derive the factors which lead to acid-base disturbances. So their idea is the traditional model seems to describe what is happening in relation to acid-base, but not why in a specific biochemical sense of the term. So this is all a lot to throw in at the beginning. So let's try a little to demystify this and try to understand what they're talking about. So let us look at some of the caveats of the traditional approach, right? I'm not calling these limitations. So the first idea is what we learned in the previous lecture, the Henderson-Hasselbalch equation. So it focuses basically on the idea that the concentration of plasma hydrogen ion is primarily determined by the bicarbonate carbonic acid system. So an excessive dependence, the implication towards the Stewart's approach is that an excessive dependence on the bicarbonate buffer system tends to ignore the effect of weak acids on acid-base physiology. That is the first thing. Second thing is, suppose I give you a blood gas report, and I don't give you a base excess, I don't give you a standard base excess, you just have a bicarbonate value. So in this situation, will it be easy or possible for us to understand what exactly are the factors that are affecting the bicarbonate? because bicarbonate can be affected primarily by metabolic disturbances, but they also change as a compensation to respiratory problems. So acidosis or alkalosis. So because of this, if you just have a bicarb value, just by looking at that, it is difficult to separate the two components. So how much of it is affected because of the respiratory part and how much of it because of the metabolic part. So what we did was we introduced a concept called as the base excess, which is a bicarb which is standardized to a normal value of PCO2, that is 40. So if PCO2 is kept constant, then what is the bicarb? So that will tell us the base excess, which will then let us know whether it's what bicarb value we are seeing is a purely metabolic component or not. So the next caveat comes in this. So we looked at the bicarbonate buffer system, but there are also other buffer systems that are in place. So hemoglobin is the main buffer in the blood, and changes in hemoglobin can significantly affect the base excess. So once we realized that, we did something to standardize that aspect as well. So base excess calculated with hemoglobin assumed to be 5 instead of 15 will now become standard base excess. We'll try to remove the effect of the hemoglobin buffer on the base excess. Now, suppose again the same thing. So suppose we have diagnosed metabolic acidosis looking at a blood gas report. Now, just from that information, do we know what is causing it? That is not possible. So what we did was we have to add on some concepts like anion gap, delta gap, and so on and so forth, in order to further delineate and clarify the causes of metabolic acidosis. So, and another thing is, anion gap again is affected by albumin and phosphate levels, which are fairly commonly abnormal in the critically ill. So, how many of us we can understand regularly compensate whenever we are calculating anion gap? How many of us look at, okay, what is the correction because of hypoalbuminemia? What is the correction because of changes in the phosphate value and so on? So we don't commonly do that. So it has to be incorporated while calculating the anion gap. So these are all the things. So you see where we are getting at. So a lot of things are descriptive. So we don't there are a few aspects of acid-base physiology we tend to get a little sideline in this particular approach. So Stewart is not exactly a new approach, right? Stewart was a Canadian biochemist who in 1981 proposed a different model of acid-base balance based on a few new concepts he has introduced. And so what he basically tried to do is he looked at some of the basic principles that are principles of physical chemistry that are applicable, looked at what are all the components of the human plasma, and then tried to combine everything together to have an overall model of the human plasma in order to explain the acid-base disturbances. So what are these laws that he looked at? So first, one is electroneutrality. So this is not something which is applied only in the Stewart approach. Whenever we calculate anion gap also, we apply the principles of electroneutrality. It basically says that in an aqueous solution in any compartment, sum of all positively charged ions must equal the sum of all negatively charged ions. So this is simple enough. So this is something which has to be fulfilled whenever we are trying to apply the model. That is the first thing. Second thing is law of mass action. So we already covered a little bit about the mass action. So what is the implication of it? The dissociation equilibria of all incompletely dissociated substances as derived from the law of mass action must be satisfied at all times. So we have these dissociation equations that we have seen before also, and we are going to see further here in this presentation as well. So we'll get to that. So, but based on this, there is some idea that starts emerging. There is something called as a strong ion. There is something called as a weak ion. So what are these? A strong ion. So these are always completely dissociated in a solution, and the resulting ions are considered as strong ions. Weak ions are substances that only partially dissociate into weak ions when they are dissolved in water. So practically, what are the strong ions? Sodium, potassium, magnesium, calcium chloride, and so forth. What are the weak ions? Albumin, phosphate, and so on. So we now have a certain differentiation of something called as strong and weak. Next, we come to conservation of mass. So the relevance of this idea is that the total concentration of an incompletely dissociated substance is the sum of the concentration of its dissociated and undissociated forms. That is also straightforward enough. So now what Stewart tried to do was take these principles and then look at all the components which constitute the human plasma. So Stewart's analysis, so what are the components of the human plasma? We will take that one by one. So the first thing is pure water. So in the traditional approach, we generally don't give much importance to water. So, but Stewart, the idea was that water has a high dielectric constant. This makes the substances to dissociate into its components. So the degree of dissociation of water is generally not considered in the traditional approach. It is very slight, but it is of great importance in Stewart's analysis. So this equilibrium is written as in a format that is familiar to us in the traditional approach as well. So H plus OH minus dissociation equals dissociation constant of water into H2, right? Now lot of very fancy equations will come up, but what I would like to emphasize is our focus right now is not how to derive these equations or not even how complex these equations are. We don't need to know those equations as well, but in each of these equations there are some clinical implications and implications for the model, and that is what we will try to focus on. So so we looked at water. Now we will look at strong ion solutions in water. So these are solutions like we discussed before, that these are ions that are effectively fully dissociated. And because their dissociation equilibria have pK values that are far removed from the local pH. So they are always present at the concentration at which they were and they do not participate in any reactions within the solution. Now we looked at that list of strong ions. The most abundant strong ions which we have to consider is sodium and chloride. Other strong ions are also there, but their values are not very high. So now, we said that we have to apply the principle of electroneutrality. So we looked at water, we looked at strong ions. Now we are going to try to combine those two equations. So if you apply the principles of electroneutrality, you come to know that basically all positive ions that we importantly considered until now, sodium, potassium, and hydrogen, all negative ions, fluoride and hydroxyl. So sum of cations minus sum of anions has to become 0. So this is one idea. So now so if we have to calculate pH from these equations, so we need to change this equation to a format where we have to calculate the H plus ion concentration. So if you solve the equation, Stewart got this equation. So it looks very complicated, but what we are just needing to understand from this is that we now have a scenario where H plus ion concentration seems to be dependent on sodium, potassium, and chloride. Sodium plus potassium minus chloride comes twice in this equation. So this seems to be important in determining the H plus concentration. Now this is a little deviation from the traditional approach. So we did not know, or we did not consider that electrolyte changes or values of the electrolytes by itself can affect the pH itself. So, but in Stewart approach, we now have come to this idea that H plus is a function of this sodium plus potassium minus chloride. Now, crudely, this can be called as strong ion difference. So this is the first idea that we get from the Stewart approach, that the H plus ion concentration may be affected by electrolyte values. So, but in a general way, we have now considered only sodium and potassium, but you can also, if you consider an overall idea, the total cations minus total anions can be considered as strong ion difference. So the most important conceptual point again and again, here we emphasize that pH seems to be not an independent thing by itself, but it seems to be dependent on something else. So you now have this concept called as a dependent variable and an independent variable, right? So we now have arrived at this strange idea that H plus, that is the pH, is actually a dependent variable which is affected by something which is imposed externally on the system. And one of those things that we now understood is that it seems to be the strong ion difference. Now, so we consider two components of the human plasma, pure water and strong ions. Now we look at weak acids. This is something so that is emphasized in the Stewart approach. So what is the weak acid? We already learned this. The weak ion means it will dissociate only partially into its components. And so if there is a weak acid called Ha, it will dissociate into H plus and A minus with a dissociation constant Ka, right? So now we apply the principle of conservation of mass. So if Ha and A minus are taking part in a reaction in a solution, so the sum total of it has to remain constant. So now we have this idea that there is some amount of weak acids that are present in the solution, and the total amount of weak acid is a constant which can be looked at. So this new terminology is called as ATOT, right? So now we have this idea that there is a solution which has all these three components. There are these dissociations of some full dissociations of strong ions, partial dissociations of weak ions, and the principle of electroneutrality has to be maintained throughout. So we now come to this idea that so strong ion difference and total amount of weak acids, they are variables which are going to affect the concentration of H plus, OH minus, A minus, HA, so on and so forth. So now we are gradually coming to a classification where we are saying, okay, these are the variables which are dependent, which means that their concentrations are determined by some other variables which are externally imposed on that system. So these two variables which are independent variables which we have considered until now, one are strong ion difference, second is total weak acid or ATOT. Now the last component of human plasma is of course carbon dioxide. So in bodily solution, carbon dioxide is again present at an externally regulated partial pressure. So this is also an independent variable. So carbon dioxide is present in multiple ways. So dissolved molecular carbon dioxide, carbonic acid, bicarbonate, carbonate, so on and so forth. So now, so the point now is, now we tend to get into this mathematical complexity. But again and again, let's focus on what we can learn clinically from this. So we have now looked at what are the principles we have to consider. We have now looked at what are the components of the human plasma, 4 components, and we have now derived all of these equilibrium equations along with electroneutrality equations. Now, ultimately, what Stewart tried to do was to combine this entire set of equations and finally derive a equation for calculating of the concentration of H plus ions. Now, don't worry about how bad that equation looks, but the point that we need to understand here is H plus is now dependent on so 3 variables which we can now consider as independent variables which are going to affect the concentration of H plus. These are strong ion difference, total weak acid, and TCO2. The rest of all the parameters that you can see in that equation, they are all constants. So the only changeable variables that is there in this equation which determine the H plus are these 3 things. So Stewart approach has 3 independent variables: strong ion difference, TCO2, and total weak acid. So any change in the pH must be because of a change in one or more of these parameters. So you look at CO2, which is controlled by the respiratory system. You look at strong ion difference, which is the electrolyte composition of the blood, which is controlled by the kidney, and you look at the so the concentration of the weak acids. So albumin, for example, produced by the liver and so on. So any of these things that are changing because of a change in the body's physiologic milieu is going to lead to an acid-base disturbance. So now we know independent variables and dependent variables, and this fact that bicarbonate and H plus are both dependent variables emphasizes the difference between traditional and Stewart approach. So now we have so briefly considered what are the principles, what are the components, how to combine these things. So finally, how is H plus determined? Now we would like to apply this model for practical application. So there are some considerations that we will look at. So first, for example, as far as the assessment of respiratory disorders in Stewart approach is concerned, it is exactly the same as the traditional approach, because Stewart also showed that PCO2 is an independent variable. So whatever we learned about how the respiratory acidosis and alkalosis happens and so on, it is exactly the same as in the Stewart approach as well. PCO2 is an independent variable, but please remember that it exists in an open system. Total carbon dioxide is not fixed because it is in equilibrium with the alveolar gas. But if you look at venous blood, fluid within the tissues, system becomes a little more close, not completely, but yes. So in this situation, you can even take total carbon dioxide content as the independent variable. So weak acids in the plasma is mostly composed of serum proteins and inorganic phosphate. Some other researchers showed that as far as proteins are concerned, albumin normally accounts for almost all of the effects of acid-base effects of plasma protein. Globulins do not play a significant role. So now, so the thing is, now we understand that H plus is influenced by some independent variables. Now we will try to understand how this works out across different compartments. So the movements of hydrogen ions between solutions will not actually affect the local hydrogen ion concentration. So what Stewart model says is that for each fluid compartment, the value of H plus depends solely on the value of the independent variable within that compartment. Now, if you add or remove H plus from any of the compartments, this is where the water equilibrium idea comes into play. So water dissociation equilibrium basically will change, and if you directly add or subtract H plus ions from a fluid compartment, water dissociation will change accordingly to that, and it will essentially provide an inexhaustible source or sink for the H plus ions. So H plus ions by itself is not going to change anything. So because water will take care of that, and H plus is affected only by independent variables. So how is it regulated across fluid compartments? So it involves manipulating, like we understood just now, one of the three independent variables. These are the three things. CO2 diffuses freely across all the membranes in the body. So therefore, it is difficult to use carbon dioxide alone to regulate the pH. So that is the first understanding. Second thing is, so now the second independent variable is protein. So proteins can't cause biologic membranes, and phosphate is regulated by mechanisms in the gut and kidney. And the primary focus of that regulatory mechanism is calcium homeostasis, not exactly acid-base regulation. So we again come to this trend that the strong ion difference is the main mechanism for generating pH differences in adjacent compartments. Now, so since we are now focused on strong ion difference, our naturally the direction goes towards the kidneys, which regulate the electrolyte balance in the body. Now the concentration, I mean, again, there are 2-3 things. One, sodium, potassium, and chloride, and so on. So plasma sodium is very tightly linked to intravascular volume, and plasma potassium also needs to be closely controlled to ensure appropriate cardiac and neuromuscular function. So if you want to regulate acid-base balance in the body, if you change the sodium significantly or if you change the potassium significantly, it will have a lot of other adverse effects on the body. So because of this, the focus shifts very essentially to chloride. So the chloride seems to be the strong ion that the kidney uses to regulate acid-base status without interfering with other important homeostatic processes. So the removal of chloride in the urine will increase the value. So please remember that H plus equals sodium plus potassium minus chloride. So if this difference increases, so say for example, chloride comes down or sodium potassium increases and so on. If this difference increases, H plus also increases. So increase in the value of the SID in the plasma. So so the removal of chloride in the urine as per that equation will increase the value of strong ion difference in the plasma. This leads to a metabolic alkalosis. On the other hand, resorption of
Dr. Guru Prasad. Just 5 more minutes you have.
So the importance, okay, so on the other hand, the resorption of additional chloride reduces the plasma state and therefore reduces the plasma pH. So gastrointestinal tract, if there is loss of gastric fluid, so these all affect the strong ion difference and therefore they affect it. So as we learned before, respiratory acidosis and alkalosis are the same. And the change in the plasma strong ion difference occurs as a compensatory response. So metabolic acidosis now in this SWOT approach might be considered to arise from conditions that either lead to a reduction in the plasma strong ion difference or increase in the weak acid. Metabolic alkalosis results in an increase in the plasma strong ion difference and decrease in the total weak acid. Right? So there is a complex mechanism for regulation of strong ion difference, but there is no such mechanism which are known to control weak acids. So last thing is, what is the strong ion difference gap? So basic idea is, so now what is the equation that we use? Sodium plus potassium minus chloride. Let us add a little more easily measurable electrolytes, magnesium, calcium, and so on. So whatever we are able to measure, the easily measurable cations and anions, if we calculate the strong ion difference from that, this is known as the apparent state because which is easily measurable. So the major weak ions that are in plasma are provided by albumin and inorganic phosphate. So if these are also taken into account and the law of electroneutrality is applied, we get into a situation where strong ion difference minus bicarb minus the effect of albumin minus the effect of phosphate should apply to electroneutrality. And so the expression for strong ion difference, if you include these two components, becomes bicarbonate. Strong ion difference equals bicarbonate plus effect of albumin plus effect of phosphate. Now there are complex equations for all of these things. Let us not go into the detail of that. This version of SID is now called as effective strong ion difference. So you have now two situations where there is an apparent strong ion difference which is measurable. There is a effective strong ion difference which is taking into account albumin and phosphate. Now if you subtract apparent strong ion and effective strong ion difference, you now end up having a value which is indicative of the unmeasured anions in the plasma. So this is a concept which is similar to anion gap in the traditional approach. So the point here, what we are trying to say is, in the anion gap, in the traditional approach, you are taking some of the electrolyte values into consideration. You have to additionally apply a correction factor for albumin, additionally apply a correction factor for phosphate, and then you will get the actual anion gap. Now, what they have done in the SWOT approach is, they have tried to incorporate the effects of all generally measurable and known factors which are influenced. So measurable and calculable factors, so which includes the electrolyte, albumin, as well as the phosphate. So if you apply the strong ion difference gap, you are now actually having a value which measures the truly unmeasured after removing the effects of all known measurable and calculable things, right? So the strong ion difference gap is a similar concept to anion gap once the latter has been corrected for contribution of albumin and phosphate. So we will just see just one example. So this is what is seen here is known as a Gamble-Graham. I mean, after so you can see on the left side there are strong cations, on the right side there are strong anions. Now, what you must understand, because of the principle of electroneutrality, any change in one of the components has to be correspondingly. So the implication is that the other compartments have to change so that the principle of electroneutrality is maintained. Now let us see for some example. So this is a common example. You give a lot of normal saline. Normal saline has a lot of chloride. We realize that a lot of regulation of strong ion difference is because of the chloride. And so if chloride increases, the chloride compartment that is there, you are seeing in the Gamble-Graham that that chloride compartment has become big. So because of that, so there has to be a compensation. If there has to be a compensation, then what is easier to do? You have to either reduce the A minus, which is the weak acids, or that is protein and phosphate. It is not easy to regulate that. So the easiest way to regulate that is to reduce the bicarbonate, which is going to lead to an acidosis. So it leads to a very simple explanation and a direct explanation of some of the electrolyte disturbance, some of the acid-base disturbances that occur because of these changes. So the same things can be applied to different things that are occurring. So plasma dilution leading to acidosis, contraction of plasma volume leading to alkalosis, so on and so forth. So the idea is that you have these application of the strong ion difference concept, and you are trying to derive what happens to acid base based on that. So now this again begs the question. This has been a matter of debate in the literature for decades now. So, but what I would like to emphasize, at least from my personal understanding, is that if we account for all of these factors, whichever approach we are using, we will eventually diagnose all the acid-base disturbances in both the approaches, right? So this conclusion has been reached by a few of the authors in the literature. Now, ultimately, what I would like to conclude with is that there is no definitive idea, as far as I understand, that the one approach is superior to other approach. So if we include all the factors, both approaches, we will diagnose all the disorders. So I mean, of course, there will be individual preferences, but the only plus point of Stewart approach seems to be that it brings into emphasis some commonly neglected considerations in the traditional approach, like influence of weak acid and influence of electrolyte abnormalities on the acid-base balance. So being practical and prudent, we should utilize both and be aware of this consideration and utilize these approaches in a complementary manner for the benefit of our patients. Thank you.
Thank you, Dr. Guru Prasad, for deliberating and taking the pain of discussing Stewart approach, which is a bit difficult. But what I understood over the years of experience, that Stewart approach gives us the importance of chloride, phosphate, albumin, calcium, especially chloride, albumin, which if you try to explain an acid-base disorder in a simpler way or in a Henderson-Hasselbalch's way, you miss these things. So over the years after discussing Stewart's approach, we take the importance of chloride, phosphate, and albumin, which is all these are very, very important in critical care setting. I think it was one of the greatest talk on Stewart approach I ever heard. Any questions? Yeah, one question came from Dr. Alok. In distal renal tubular acidosis, we are unable to excrete H+. causing decrease in pH. This appears as H plus increase affects the pH of fluid. So how should we understand this distal RT using Stewart approach? Good question. Excellent question.
Yeah.
So
So,
can you just stop your screen sharing?
yeah. Right. So, so the thing is, as far as the distal RTA, there are two considerations here. One is that you look at, distal RTA is a situation we generally said that inside a closed compartment, H plus going up and down should not by itself lead to significant changes in the pH. But in Stewart, so in distal RTA, you have a situation where the changes in the H plus ion concentration is no longer inside a closed compartment because there is an abnormality and there is a loss. There is an abnormal function in the kidney which is changing this. But if you look at Stewart approach, they will probably say that, okay, even if there is something wrong with the kidney and the H plus goes up and down because of it, the water dissociation should compensate for that. The problem is water dissociation is very slight. So it is very difficult to assume that in this kind of situation, the water will dissociate so much that it is by itself enough to correct the entire H plus disturbance that is happening because of the problem in the kidneys. So I would say, but we should also understand that in RTA, for example, chloride, it will be the anion gap will be normal. So if you are having an acidosis which is low bicarbonate and you are having an anion gap which is normal, one of the other anions should change in order to compensate and maintain the electron neutrality, which means that the chloride is going to become more. So that is the way probably we should approach the situation in distal RTA with Stewart.
So thank you, Dr. Guru Prasad. So for the sake of
invite comments, because Stewart approach is not something we also use on a regular basis. So
correct.
I would request the other experts to chip in if there are any other considerations that I have missed.
Correct. So we'll continue the discussion in the chat box. So for the sake of time, we will move to our last session, which is also very interesting and important for our day-to-day practice, which is metabolic acidosis. And for that talk, we have Dr. Kaushik Maulik with us. Kaushik is very close to me. He did MD from PGI and as well as DM Pediatric Critical Care from JIPMER. Right now, he is there in Apollo as well as in ICH. And Kaushik, the stage is yours.
Okay, am I visible and audible?
You are visible, audible. Please share your screen.
Yes, screen is shared. So, okay.
Below screen share, the green one.
Yes, exactly. Is my screen visible?
Yes, perfect.
Okay, so shall I start?
Please go ahead.
Yes, so first of all, I'd like to thank West Bengal Academy of Pediatrics for this opportunity and for the fact that I am able to attend today these wonderful sessions. So my topic will be on metabolic acidosis, anion gap, delta ratio, case-based analysis. So basically, this is the topic which has been given to me. So just the last talk was on Stewart approach. I'd like to reiterate that it was an excellent talk by Dr. Guru Prasad. And I myself find Stewart approach difficult to understand. And this presentation and this talk will be an entirely non-Stewart Henderson-Hasselbalch approach. Okay, so is my slide changing?
First slide is there. Can you just change your slide once?
Yes, I am trying to do so, but okay. I'll go by this thing that is below. Now it is changing.
Perfect.
Yes. So so the points to discuss here would be the definition of metabolic acidosis, simple things. So concept of anion gap, then the delta ratio, then a few case-based discussions, and then a few questions. Okay. So Okay, so what is metabolic acidosis? So basically it is defined acidosis when my pH is less than 7.35 and my serum bicarbonate is less than the normal value, that is, it is less than around 22. So it basically reflects a state where there is acidosis or deficiency of base, that is bicarbonate. So this is essentially what we mean by metabolic acidosis. Okay. So as we have heard in our sessions that when we have metabolic acidosis, then the body obviously tries to compensate the pH via the respiratory system. So there will obviously be hyperventilation with a CO2 washout. And in these occasions, we basically have an expected PCO2 that is given by a formula known as the Winter's formula. So the expected PCO2 in millimeters of mercury is 1.5 multiplied by the bicarbonate concentration plus 8 plus minus 2. So whenever we are encountering a metabolic acidosis, so we can have an expected PCO2 as to if the body is trying to compensate the metabolic acidosis properly, then what the PCO2 should be. So we can have a brief and rough idea of that PCO2 from this formula. Okay, so here is the reference from where it is taken. The other compensations are also given, which will be discussed in the subsequent sessions. So now what is anion gap? So whenever we are encountering a metabolic acidosis in our blood gas, we have to bring into consideration something known as the anion gap, because our approach to metabolic acidosis depends on that, and also the pathophysiology is dependent on it significantly. So our anion gap is basically, it's a difference between the measured cations and the measured anions, or it can also be told as a difference between the unmeasured cations and the unmeasured anions. As we discussed just some time back, the concept of electroneutrality. So the normal anion gap, you will get different references. Somewhere it will be written 10 plus minus 2, somewhere it will be written 12 plus minus 2. So roughly it is around 10 to 12. And also it is significantly dependent on albumin. And every 1 gram per deciliter decrease in albumin concentration decreases the anion gap by approximately 2.5. Because we know that many of our electrolytes which are there, they are also bound to albumin. And the anion gap correction for albumin is basically sodium minus chloride and bicarbonate, plus you have to add the correction factor, that is 2.5 into 4 minus albumin. So whenever there is hypoalbuminemia, you have to correct the anion gap for the hypoalbuminemia. This is a very significant point to remember. Okay, so now if we diagrammatically represent, so basically the concept of electroneutrality, you see, so what is happening? So this is sodium, that is the cation, and these are my anions. So anions are chloride, bicarbonate, and some unmeasured anions. So for electroneutrality, if sodium is 140, the sum of the anions should be 140. So if chloride is 106, bicarb is 24, unmeasured anion has to be 10. So now, when metabolic acidosis is happening, basically, the dynamics is changing. So how the dynamics is changing? One thing can be that your chloride is increasing and your bicarbonate is falling, but your unmeasured anions are basically remaining same. So this makes what is known as a normal anion gap acidosis. Why? Because sodium is constant and you're in the chloride plus bicarbonate, the sum of chloride and bicarbonate are constant. So only what happened is that in the sum of chloride and bicarbonate, chloride increased and bicarbonate decreased. There was no increase in the unmeasured anion. So this is a normal anion gap metabolic acidosis, typically given by the typical examples are the hyperchloremic acidosis. And then there is what is known as the high anion gap acidosis. So what is high anion gap acidosis? So basically what is happening is that there is an increase in the unmeasured anion component. So as a result, what is happening? The unmeasured anion component is increasing. So your chloride plus bicarbonate combination is actually decreasing. And as we know, we measured the anion gap by sodium minus of chloride plus bicarbonate. So if that component is decreasing, so your anion gap is rising, and that anion gap is reflected by the unmeasured anions which have increased in your plasma. Okay, so now next, when we have addressed the anion gap, so whenever we are encountering high anion gap, so we must remember that in situation of metabolic acidosis, in a high anion gap, it may not always be a pure high anion gap metabolic acidosis. So what I mean is that, so high anion gap metabolic acidosis is there, but along with that, it may be so that there is a component of associated normal anion gap metabolic acidosis, or there is an associated component of metabolic alkalosis. So how do we find that out? That is found out with the help of something known as the delta anion gap, delta bicarb, and delta ratio. So what is the delta ratio? Delta ratio is the delta anion gap divided by the delta bicarb. So what is delta anion gap? So we calculate the anion gap in the blood gas and we subtract 12, that is the normal anion gap from it. And what is delta bicarb? So 24 minus bicarbonate. We know that the 24 is the normal bicarbonate level and this bicarbonate is the bicarbonate value that is there in the blood gas. So if we get this ratio, we may have the following values. One can be like it can be less than 0.4. This typically happens when there is a hyperchloremic normal anion gap metabolic acidosis only. If it is 0.4 to 0.8, so it is a combination of high anion gap metabolic acidosis and the normal anion gap metabolic acidosis. If it is 1 to 2, so it is an uncomplicated pure high anion gap metabolic acidosis. And if it is more than 2, probably there is an added component of metabolic alkalosis. Okay, so whenever we are analyzing the blood gas, finding metabolic acidosis, so we must see the anion gap. If we find a high anion gap, we must calculate the delta ratio to find whether there is an associated component of normal anion gap metabolic acidosis or metabolic alkalosis in it. So this will reflect on our subsequent discussions, which are case-based. So we have kept very simple practical cases, which we see in our day-to-day life. So 7-year-old child had profuse loose stools for 5 days, has not taken ORS properly, urine output is mildly reduced, and our dehydration is present. So we have the blood gas here, which shows a pH of 7.127. Then our so bicarbonate is 18 here. Okay, and we have a sodium of 163, chloride of 133. Okay, so and our lactate is 0.6. So if we go by the analysis, we see, is there acidosis? Yes. Is the acidosis metabolic? Bicarb is low. Yes. What is the anion gap? Anion gap is 12. That is normal. The calculation is shown here. So the impression is a normal anion gap metabolic acidosis. What is the etiology? Etiology is a loose stool, which has happened. And can you see the chloride here? The chloride level is so high. Probably child has received some chloride containing fluid, bolus, or some IV fluid infusion from outside. And also you get the expected PCO2. Always you should see in these blood gases. So here the expected PCO2 is coming 33 to 37 millimeters of mercury as per Winter's formula. But here the PCO2 is 66. So probably it might have been so that the patient is having an added respiratory acidosis due to some reason. So if your PCO2 is more than your expected PCO2, then there is an added component of respiratory acidosis. If your PCO2 is less than your expected PCO2, then there is an added component of respiratory alkalosis. That is why whenever we are getting metabolic acidosis in a blood gas, it is also important to check the expected PCO2 and compare with the PCO2 in the blood gas as per the Winter's formula. Okay, so now we come to case 2. So case 2 is a 7-year-old boy again. So an adenoviral ARDS with nosocomial infection in septic shock in PICU on 2 vasopressors. This is the blood gas. So if we see pH of 7.379, PCO2 of 30.6, PO2 of 49.7. So the patient is on the ventilator and our saturation is 81.4%, very sick. Lactate of 3.4, sodium 138, chloride 101, and our bicarbonate level is 19.2. So then again, we go to the next step, that is how to analyze. So one point you must remember here, we must mention, I think it has been mentioned before, I joined late, but any blood gas, whenever we get, we should check the consistency of the blood gas. Okay, so that to see that the values are consistent and they are not spurious values. That is the first step. After that, when we are analyzing, like here again, you see that acidosis is there. So the pH is 7.379, just above 7.35. So you may not say it is there, but it is just on the verge of acidosis. So metabolic wise, you see bicarbonate of 19.2. We know that the normal value of bicarb is around 24. So yes, it is low. My anion gap is 18, that is high. And if I calculate the delta ratio, I find that it's a pure high anion gap metabolic acidosis. And the lactate is 3.4. So the reason is basically a lactic acidosis due to shock, and the lactate is 3.4, and my expected PCO2 here is 34.5 to 38.5. Here it is 30.6. So basically there is a component of mild respiratory alkalosis which has probably just pushed the pH above 7.35. Okay, so now we come to case 3. It's a 4-year-old girl, known case of a systemic onset JIA with macrophage activation syndrome and multi-organ dysfunction in liver failure, sepsis with septic shock on 3 vasopressors, and received a lot of crystalloids for resuscitation. So here we have the blood gas, which is showing a pH of 7.298, PO2 of 92.9, PCO2 of 41.2. So our bicarb is 19.5 again. Our lactate is 9.7, sodium of 160, chloride of 126. So these we have the values. So here, if we analyze, we'll find that is there acidosis? Yes, we can see the pH. Is it metabolic? My bicarb is 19.5. Yes, again. Anion gap 15. We know normal anion gap is around 12, but some people say maybe up to 14. But yes, anion gap is high. And if we see the delta ratio, it comes to 0.6. So it's basically a combined high and normal anion gap metabolic acidosis. What is the reason? So high anion gap is due to the high lactate, and the normal anion gap is due to the high chloride containing crystalloid resuscitation that has been done. We can see that the chloride level is 126. And the expected PCO2 here again is 34.5 to 38.5. Here the PCO2 is 41.2. So there is a component of a mild added respiratory acidosis along with it. So now we come to case 4, next case. So we have a 4-year-old male child, septic shock, received a lot of boluses, now stabilized. And now we have started on a diuretic infusion to treat fluid overload, a Lasix infusion, before we extubate. So now we have the blood gas, the values pH 7.32, PO2 72, PCO2 40, bicarbonate of 20, sodium of 138, potassium of 3.1, chloride of 98, and a lactate of 2.3. So how do you analyze? On analysis, is there acidosis? Yes. Is it metabolic? Yes. The anion gap is 20, which is high. Delta ratio of 2. And the expected PCO2 36 to 40 millimeters of mercury. Here the PCO2 is 40. So what is it? So it is basically a mixture of high anion gap metabolic acidosis with metabolic alkalosis. So although the bicarb is only 20, you see that we are mentioning here metabolic alkalosis. Why? Because your delta ratio is 2. It is indicating basically that the furosemide infusion has caused an added component of metabolic alkalosis, which is not at all obvious from this blood gas if you do not calculate the delta ratio. So this is how the delta ratio helps us when there are mixed acid-base disorders. So we have to understand it. So now basically what is the concept behind this delta ratio? So basically what happens is that, so when our compensations and all are taking place, and when these changes are happening, the anion gap and the bicarb basically move proportionately. The change in the values of anion gap and the bicarb move proportionately. So the change in anion gap should roughly be equal to the change in bicarb, making the delta anion gap and delta bicarb roughly equal if it is a high anion gap metabolic acidosis. If there are added components, like if there is an added normal anion gap metabolic acidosis, then what will happen is that the change in bicarb will be more. As a result, your delta ratio falls down. And if there is an added component of alkalosis, then the change in bicarb will be less. So as a result, your delta ratio goes up. So this is how the delta ratio functions. Okay, now we have case 5, a 6-month-old baby with respiratory distress and encephalopathy developed over 2 days. A history of sibling death is there. And also there is a history of consanguineous marriage. So here we have the values, pH of 6.735, PCO2 of 26.1, PO2 of 74.5, hemoglobin of only 2, lactate of 22, sodium of 128, chloride of 103, potassium of 6.1, and a bicarb of 3.7. So what is the analysis of this blood gas? Dr. Rohit, is this open to the audience? Can any one of them answer?
Yes.
Yes, so
They can answer. They are answering also.
Will anyone be willing to answer this?
Yeah, somebody has written inborn error.
Oh, no, that is the diagnosis, but the stepwise analysis, the steps which we are discussing. So obviously in this situation, we'll suspect inborn error metabolism, we'll suspect sepsis. Yes, but that is the etiology, but the stepwise analysis. So like
Steps they are writing. First
Okay.
step is somebody has written severe, Dr. Narayan, severe metabolic acidosis.
Okay.
Then acidemia, then acidosis metabolic.
Okay.
Answers are coming.
Very good.
Severe metabolic acidosis with respiratory alkalosis.
Okay.
Asthma.
Okay.
Many answers are coming.
Very good. And what about the delta ratio? Anything?
Can somebody calculate delta ratio?
Won't be that tough, I think. So our anion gap is around 25 minus 4, 21.
Asthma with respect 21.3. Dr. Madhu has written.
That is the anion gap. Yes. So what is the
Anion gap is 2.
I think we have
Somebody can
time.
write.
That is why I'm discussing.
Yes, we have time. This is the last session and interactive session. Anion gap high. Somebody has written yes. Asthma with uncompensated respiratory alkalosis. Asthma with added respiratory acidosis. Delta ratio 0.45. Hello?
Yes. Okay. So I think we have had answers. Many answers are coming up, which is very.
But one question came: should we calculate corrected anion gap for all patients with albumin less than 4.5?
Questions together, I think. I'll just give the analysis. Okay.
Asthma with addition respiratory acidosis. Last answer. Yeah.
Okay.
Please go ahead.
Is there acidosis? Yes. It is metabolic. Yes. Bicarb is 3.7. Anion gap around 24, maybe, or 21, what you calculated. It is high anyways, 128 minus 103 minus 3.7. Delta ratio of around 0.6. So it's a mixed normal and high anion gap metabolic acidosis. And the reason for the high anion gap acidosis is obviously your lactate, which is very high. So expected PCO2 is 12 to 16. This child's PCO2 is 28, 26.1. So this child was encephalopathic and was possibly not breathing well. So ultimately, this child had got intubated. Like that was the reason. So if you see this PCO2, apparently it will seem to you as if there is a lot of CO2 washout. But as per the compensation formula, this PCO2 is actually higher than what it should be. So actually, it is reflecting that there is a associated respiratory acidosis in this patient. Although the value of the PCO2 is alkalotic. So like it may sound paradoxical, but if you analyze carefully, this is what this blood gas is showing. Okay, so I end here. So, and I think we can make it open for discussions, probably, Dr. Rohit.
Yes. Thank you. Very discussion and a common topic for our day-to-day discussion, day-to-day classes, and day-to-day cases also. Yeah. So actually, I will take this question.
Yes.
I always like this question. This
Sure.
question. Then other also can add on. Always compensated. Just add on one question. Is if the expected PCO2? Where is the question?
Yeah, they have.
Sir, if PCO2, yeah.
Yeah, they have
if
asked.
the PCO2 below the compensation level, then we can say it is uncompensated metabolic acidosis. I'll just add on one point. This compensation, uncompensation, partial compensation. So you uncompensated versus compensated. What is this? This is the pH. Remember, if you see your pH is in the hello.
Hello.
Rohit.
Rohit sir, I think some problem from your network, I think.
Yes, it seems that.
Yeah, he has some
problem with
issues. So
you can take over.
Yeah. In the meantime, Dr. Kaushik, there was one question where they have asked that what was the this one? Any correction formula for low phosphate and elevated lactate? They have asked.
So there is something called the lactate adjusted anion gap. So the lactate adjusted anion gap is basically the subtraction of the lactate value from the anion gap value which is there. So with that we get the lactate adjusted anion gap. But I don't think that there is a correction value for phosphate or for phosphate at least, because I've never encountered that. Other experts can help, and possibly the Stewart approach might help.
Yeah, Rohit sir, you want to add anything? This question.
Regarding
Yeah.
the compensation, that always this question asked, is that compensation or under compensation, or it is the process of happening? So remember, if your pH is in between 7.35 to 7.45, it is compensated. The first and foremost is all compensated means it is in the range of normalcy. If it is not in the range of normalcy, suppose it is more than 7.45, so there is some alkalosis is still sitting. Then you have to find out, as Kaushik said. If it is below 7.35, near 7.35, then something is in the acidic range. So then you go, again, we have 7 steps of acid-base discussion on tomorrow's 7 steps of acid-base analysis.
Yeah, and another question was why we are not considering potassium in the anion gap. Anybody can take, I think.
Yes.
It can be considered actually. I mean, that is why people say that there are 2 ranges given for anion gap. Some people say it's 10. You can consider it, but if you consider it, then your normal anion gap will increase.
Yeah. So
Obviously,
there is
because the
value for that.
potassium is getting added to it. So your normal range will just increase a little bit. That's it.
Sure.
So you can do that, but if you do that, then your normal anion gap range will also increase by the same amount.
Okay. So Anand is asking, can you give some condition with mixed ABG?
Yes, like as we discussed, the clinical scenarios which we discussed right now, they were the scenarios which are mixed ABGs. Like the classical examples are high anion gap metabolic acidosis with a normal anion gap metabolic acidosis. Like a diabetic ketoacidosis we have treated. Initially high anion gap metabolic acidosis. Then we give a lot of fluids, correct the dehydration, and then later we find out, if you can see the blood gases delta ratios, that if there is an added component of normal anion gap acidosis also. That is due to the chloride in the fluids that is there. And that is why the fluids which are given these days, we prefer to give balanced salt solutions which have low chloride, etc. Then again, typical scenario given where there is a high anion gap metabolic acidosis with an associated metabolic alkalosis, like that patient who was in septic shock, resuscitated, then subsequently at a stage came when we were thinking about, okay, the child is now volume overloaded, we will diurese a bit. We added some furosemide, and furosemide added a component of alkalosis to it. As a result of that, the delta ratio became around 2. So then the child had some metabolic acidosis, high anion gap also, with an added component of a metabolic alkalosis. So these are the typical scenarios where we get mixed acid-base disorders. And if we don't calculate the delta ratio, by looking at the blood gas, it is impossible to suspect it. So we may entirely miss it. So that is why we should make it a routine practice whenever we are encountering metabolic acidosis to check the anion gap and to check the delta ratio if we have a high anion gap.
Yeah.
Actually, the example of Kaushik is very nice. The decay. If you read, if you sit beside a decay patient and analysis it step by step, you will learn. And Kaushik started with decay. What he said is high anion gap acidosis plus because of chloride, the patient become also has this normal anion gap acidosis or hyperchloremic metabolic acidosis. The same patient can go to now. For decay, the high anion gap can be corrected. So ketosis corrected. For chloride, your normal anion gap is still remaining, day 3, day 4. The same patient may have a AKI. Now again, high anion gap because of AKI, not because of your diabetes. Because you are measuring ketone is normal.
Yes.
Beautiful. The same patient is going from one spectrum to another.
And sometimes you will see that patient is improving, but the child is still having acidosis. that can be explained by chloremia.
And as well as your AKI.
Yeah. Another one, this is by Sayantan. So, sir, is there anything called corrected bicarbonate value? I think Agni sir can take this.
I was thinking. I have not heard of it, and I do not understand what you are correcting it for. No, I don't think it is usually used. It is something that is commonly used. I don't think so. And if whoever has asked the question, it will be better if you can see what is it being corrected for. Then we may be able to sort of, say something like, someone just said, can you corrected phosphate anion gap? Somebody just said that, or corrected. I mean, what does that mean? But what is anion gap? Your anion gap is basically your unmeasured anions minus your unmeasured cations, right? And phosphate is one of your unmeasured anions, because phosphate is something which comes within the anion gap, but we do not measure it. So if you say, I will just, reduce the phosphate bit from my anion gap and call it a phosphate corrected anion gap, you can call it. Then it becomes phosphate corrected, because from the anion gap component, we have taken the phosphate out of it. So this anion gap is the anion gap that I am getting, but I am taking the effect of phosphate out of it. That is what it is saying. You can do that. I don't know what will be the use of it, but that is what it is doing.
Mostly we are not using it. Okay, we'll go to the next one. Sir, when to add soda bicarb fluid with metabolic acidosis? Dr. Guru Prasad, maybe.
Right. So, see, sodium bicarbonate seems like a reflex answer to treat any metabolic acidosis, but that is a very dangerous thing to do. So there are 2-3 considerations why you should not do like that. First is that, see, soda bicarb, the carbonic acid system that is there, it will get converted into H2O and CO2. So soda bicarb by itself may not go into the brain and do something, but CO2 easily diffuses across everything. So you are giving bicarbonate, which should make an alkalosis to the child, but the CO2 that is produced from that bicarbonate will go into the brain and cause acidosis. So this is known as paradoxical CNS acidosis. So so if you are just trying to give correct metabolic acidosis using soda bicarb, you might actually cause harm to the patient, and the CNS depression may become worse, and so on and so forth. Second thing is, see, the acidosis is in a lot of situations is coming at the tissue level. So any amount of bicarb that you give in these kind of situations is honestly not going to correct the pH if you do not treat the underlying cause. You try treating a child with septic shock, for example, so tissues have already gone into anaerobic metabolism, lactic acidosis is present. So if you try to just correct that, it is almost impossible to do if you don't correct the shock and improve the tissue perfusion. So for all these reasons, it is highly inappropriate to blindly give soda bicarb to any metabolic acidosis. The actual indications would be like, for example, if you are dealing with a IEM in a metabolic crisis, that is one situation where you can consider. Second thing is, if you are treating severe hyperkalemia. Third thing is that, so there are some studies in adults, for example, bicarb trial, where they have said that in severe AKI, stage 2-3 plus. So in those kind of situations, if you give bicarb and maintain the pH above 7.2, you may reduce the incidence of needing renal replacement therapy. So these may be very few indications where you would consider giving bicarb, but generally no.
Perfect.
Let me just
Yes, sir. Yeah, please.
add something. I mean, for not giving bicarb, another point will be, if you're acidotic, then your hemoglobin dissociation curve is shifted. do you call it right or left? Basically, then hemoglobin will give up more oxygen. The oxygen delivery to the tissue will be better if you are acidotic. And oftentimes, if you are acidotic, you are not perfusing very well and your tissue delivery oxygen is not good. If you make that person alkalotic, then hemoglobin will deliver even less oxygen to the tissue. So that way, correcting the pH may be bad for the tissue beds. But one possibly, the way I look at it is, if you think that your pH is so low that it is affecting your cardiac contractility and it is affecting your heart pump, then that is something that can, make everything worse. And that may be one area where, I mean, if you think that this pH is actually driving my heart down, then you may think about giving some bicarb possibly. And of course, the hyperkalemia, definitely, if you are hyperkalemic and you are acidotic at the same time, then correcting the acidosis will help the hyperkalemia.
So,
Cardiac
just
arrest rate, sir.
one thing I wanted to ask here. So, like you said, in this particular situation, we all face this situation where the pH is so low that we feel there is hemodynamic instability and myocardial depression because of that, and the inotropes are not acting. So, is there any specific guideline as to how low the pH should be to consider this, or is it more of a clinical judgment? Because some books will say 7.2, some literature will say go down to 6.9. If it is less than 6.9 and you are hemodynamically unstable, then you can consider. So is there any particular value that we can rely on, or is it more of a clinical judgment?
I'm not aware of any evidence. This is mostly, theory. This is mostly theory. I mean, how can you get a clinic? I mean, you will not do a study and drive the acidosis to that level to figure out what actually happens. But I will say 7.2 is definitely too high, way too high to say anything less than 7.2 and you give a bit of bicarb. Definitely not. 7.2 is way too high. Whether I will say if it is you are hitting 6, so you are less than 7.0. Then I think you are definitely going into that sort of region.
Okay, Rohit sir, want to add something, or we'll go to the next one?
No, we'll go. I answered one more. So one question, one point like base excess and base deficit. Kaushik, if you want to add that point, I think. Kaushik, unmute, please.
Yeah. Dr. Kaushik, you are muted.
No.
So base excess and base deficit are basically the reflections which are put in the blood gas based upon whether you are having a metabolic acidosis or you are having a metabolic alkalosis. That means whether your bicarb is more than normal or your bicarb is less than normal. So bicarb is the base. So that is reflected by a standard base excess or a standard base deficit. If your bicarb is less, that is your metabolic acidosis is there. So you have a base deficit, which is reflected usually in a negative value. Normal value of base excess or deficit is around -4 to +4. So anything less than -4, that will indicate a significant base deficit, and anything more than +4 will indicate that there is a significant base excess.
Okay.
One more thing.
Yes, sir.
I use. I mean, a lot of people go by bicarb. I use base deficit. Base excess much more. One thing is, when you are doing base excess or base deficit, you standardize your PCO2 to 40. So even if your PCO2 is not 40, it is calculated as if your PCO2 is 40. Thereby, it actually removes the respiratory component completely out of the equation. So your base deficit or your base excess is just the pure metabolic component of the thing. So when you say base excess or base deficit, it is assumed what would be how much bicarb you need to add or take out to keep the pH 7.4, assuming your PCO2 to be 40, even if it is not. So that way, it is taking the respiratory component completely out of the equation and giving you only the metabolic component.
Nice. Sir, next one is someone asked about urinary anion gap, osmolality gap. That is.
We will leave it.
Yeah.
We will take this question. So standard bicarbonate versus that
Actual by cup.
calculated by cup and actual by
Actual.
cup. Which
Yeah,
one
yeah.
to take? In ABG, all will be there. Standard versus actual.
Yeah, that one Dr. Kaushik can take, I think.
Also, it will be Dr. Niladri will take tomorrow, like which one to take, all like pitfalls of.
Yes, like I mean, we usually take the standardized one. Okay. But I think practices may differ. But which one to take exactly, I'm not exactly
Standard.
sure.
Standard.
But we take the standard
Guru,
one.
Guru Prasad also to take standard or actual. I think it is standardization with temperature and some internal parameters.
Yes, but
all of us.
whether that makes a difference or not that much, I don't know. I mean, in the temperature and all those stuff. But we take
so
the
the standard basis is mostly to account for hemoglobin changes. I think that is
Yes,
what.
yes.
Yeah. So hemoglobin has a buffer effect, and so if there are significant changes in the hemoglobin, that may affect it. So they have found that if you take hemoglobin calculated for hemoglobin 5 instead of 15, that will solve the problem. I mean, I don't understand the nitty-gritties of that, but that is what is described in the literature.
Okay.
So yeah. So we will put this answer in the WhatsApp group as time is too. So these questions, can you just put in the WhatsApp group? We'll try to answer with references. So thank you all the speakers and seniors for having with us, and all the active participants for continuously asking questions. So I'll hand over the mic to Mihir sir or Kalpana ma'am or any senior faculty from WBAP. Sumantroda.
Nice one. No comments. Nice one. Nice academics.
Okay, thank you. So anybody, any senior faculty is there? Kalpana ma'am. So thank you all. We will again meet tomorrow at 6 o'clock. Please be with us, and please do interact. Please put your questions in the WhatsApp panel. Any of the faculty will answer that, and we'll have same times. The link will be shared with you in the WhatsApp group. And tomorrow we have quiz at the end of the session, which will be based on the topics we are discussing. So thank you. Good night. Thank you, sir.
Thank you
all.
Good night.
Thank
Good
you, sir.
night.
Mesa is there, sir?
Okay, Rohit, just end it. Just not issue. Okay.